Good evening and welcome to the Heart Failure Conflux 2026. We start the program with the abstract session. We had a good number of abstracts and we selected six of them that will be presented today. So the session will start now with the judges taking over. I invite Dr. Professor C.C. Karta, who is our organizing chairman, to say a word and then we will go to the judges.
Thank you, Hari. I mean, it is an honor for me to be associated with the Heart Conflux. I think this is the sixth edition of this meeting, and it is certainly we are thankful to the Heart Failure Association of India for agreeing to host this meeting. So I welcome everyone, and particularly the young delegates. I don't know who are the young delegates. I have not seen the list yet. So I look forward to listening to them.
Thank you, sir. We will invite the judges now. Dr. Shivakumar, who was the head of the Cellular and Molecular Cardiology Division at Sri Chitra Institute. Now is a professor at ICMR. And Dr. Biju Soman, professor at Achuamenon Center. Dr. Needu Mohan, currently heading the Department of Molecular and Cellular Cardiology at Sri Chitra, and Dr. Madhusudanan, who is a professor at Biochemistry Department of Sri Chitra. So these people will be judging the abstracts, and please request the participant to keep the time. And over to judges, Dr. Shivakumar and team can take over. The first, you can invite the first presenter according to the list.
Thank you, Dr. Harikrishnan. Let's get started. So the
please,
first presentation, please stick to participants, contestants, please stick to time. It's extremely important.
First presentation is by Sangam Dinesh Reddy.
Sir, I am here, sir.
Yeah. Please start your presentation here.
Now I have to share this thing.
Yeah. Vinay, you can help him.
Yes, sir. So you just click on the share here, and you will see your PPT.
Yeah, we are seeing your screen. Yeah. Go to the full screen, please. Yeah. Please start. Your time starts now.
Sir, good evening, sir. Good evening, all the stalwarts and professors and my colleagues. My name is Dr. Dinesh Reddy, and I will be presenting OUI-HF. It is a novel concept, a digital twin derived composite index for early prediction of heart failure decompensation. Mainly, this work explores how multi-device data means we are taking so many parameters like heart rate, so many index variabilities and anything. How these data streams can be condensed into a single interpretable digital signal to support early clinical decision making in heart failure management. Sir, remote heart failure monitoring today relies on fragmented device data, sir, like heart rate, activity, body weight, and blood pressure. So often they are always interpreted in isolation only. So early decompensation signals are subtle and trend based, and they might be missed without integrated analysis. So this increases clinician burden and delays intervention. So the goal is to move from data overload to a holistic, actionable risk signal, sir. Coming to the concept, OUI-HF is a digital twin-derived composite index scaled from 0 to 100, integrating parameter trends. It reflects functional severity, predicts short-term decompensation risk before the overt heart failure happens. The output is a single interpretable score to guide clinical triage. Coming to the objective, it is a digital twin-derived composite index. So we have to stratify we developed and evaluated this index for stratifying 7-day heart failure decompensation risk using wearable and home monitoring data in a simulated setting. So we are using not the real patient data, we are using synthetic cohorts, sir. Coming to the methodology, we took 10,000 synthetic heart failure digital twins, which are stratified by Newark Heart Classification from class 2 to class 4. We generated them, 10,000 synthetic heart failure digital twins. We did continuous simulated data streams, including heart rate, activity, weight, and blood pressure. YOHF was computed as a normalized composite score. So performance was assessed by stratification and ROC analysis. So coming to the this is the distribution of OOHF in synthetic HF digital twin cohorts. Means it is in the count on the y-axis and score in the x-axis. This is another figure which shows is the NYHA functional class 2 to 4. This is the ROC curve. On the y-axis it is the positive rate, x-axis is the false positive rate. So we are comparing the baseline model with baseline plus YYHF index. So what are the, we got the distribution of YOHF scores was broad and right skewed, sir. We got the results there. We are very broad and right skewed, indicating effective risk stratification rather than clustering. If clustering happens, there might be issues. So which indicates the very effective risk stratification. This is another ROC curve, 7-day heart failure decompensation prediction. May we compare the baseline model plus baseline plus YY heart failure index. The inclusion of YYHF yields comparable AFC to the baseline model means 0.8 to 0.82. Nearly identical ROC curves indicate that heart failure preserves discriminative, this index preserves discriminative power while adding the value of a single digital signal for clinical workflow. From data deluge to signal, we have condensed the multi-device streams into an interpretable digital signal, which also decreases the cognitive burden, means cognitive offloading, removes the need for clinicians to manually correlate disparate parameters, reducing load and highlighting relevant trends. So workflow and triad support is like, sir, early warning system, identifies subtle deterioration before the heart failure. It prioritizes interpretability while AVC is preserved. It also reduces alert fatigue, standardizes risk communication to minimize false alarms associated and with the isolated parameter spikes. So what are the limitations, sir? And what are the future directions? Findings are derived from a digital twin cohort. So these are not the real world process, but statistically robust. The data lacks the behavioral artifacts and noise inherent in human subjects. So we need validation also. External validity remains to be tested. Calibration against real world clinical outcomes is required to ensure simulated risk data, which can be translated to effective care. So there is we are also planning a roadmap for the validation. We need prospective clinical trials to use it real world variables, define actionable thresholds for it, means establish sensitivity cutoffs for the alerts. We can integrate this into EHR by embedding scores into clinical workforce. The ultimate goal is, sir, clinician in the loop, sir. Means we are using so many devices which are in the automated, means in the diabetes we are using everything is in closed loop system, sir. So the ultimate goal will be clinician in the loop, moving from in silico concept to bedside utility. Conclusion, it can be it is very scalable, sir. It serves as a robust proof of concept index that successfully integrates multi-device streams. It can be its interpretability can be enhanced by preserving discriminative power. Future direction is clinical validation using real-world variable data, which is warranted to assess utility in routine heart failure management. Disclosures and data ethics. The study utilizes computationally generated digital twin core.
Thank you, Dr. Dinesh. I think you exceeded the time.
Yeah.
I think we'll have to move forward. Over to Dr. Biju Soman and the team for the questions. Biju?
Yeah. Thank you.
Sir,
Thank
good evening,
you,
sir. Biju, sir.
Yeah, good evening. Good evening, Dr. Dinesh. Actually, good, very good study. Actually, it's interesting that you have done this study, and now you are seeing
Sir, very happy to see you, sir. You taught us R
high-skewed
Studio for
nature.
us. Hmm.
Yeah, that's good. And you are seeing a R-skewed nature, and you are claiming that this R-skewed nature is adding to the discriminative power of this tool.
Sir.
It would have been good, actually. Am I audible?
Yes, sir. Yes, sir. Very, I mean, sir, very small audio. Very less, I can.
Uh, uh, mm, how is it now?
Okay, sir. Okay, okay, sir.
So, uh, you haven't done any sort of quartile-based analysis and all, no? Actually, you are
Sir,
just
actually, I
claiming
used,
the right-skewed nature and the clustering.
sir. Sir,
Yeah, go ahead.
actually I used the Anaconda Navigator, this Python based this thing, and we generated the synthetic cohorts using Jupyter Notebook profile, sir.
Yeah, that's right. Actually, I'm looking at have you used any statistical test to see whether the discriminatory power of this test is having some added advantage over the diagnosis?
Yes, sir. Yes.
Which test you use?
Means we can,
Because
sir, these are all parameters, sir. These are all this is all synthetic data, sir. So the study establishes feasibility, sir.
Yeah, no, I agree. Actually, they're all good, but I'm suggesting that it would have been good actually if you do some quartile based comparison or some sort of a risk gradient. Right now, you are stating that the right skewed nature and the clustering of the cases towards this extreme
Sir, for
values
sir,
the discriminatory
actually, for
power.
if you are doing a group comparison test, we might use the independent t-test, man-Whitney test, sir. If it is normally distributed, sir, means you are asking
Yeah,
specifically about statistics.
Crucial values test, actually, if you do, that will be good. Okay.
Sir.
Okay, thank you.
Thank you, sir. Thank you.
Any other questions from the other judges?
Now, Dr. Dinesh, just one small question. In one of those figures that you showed, the scatter appears to be too much, isn't it?
Scatter, sir.
The
The first
scatter,
figure,
the
sir.
scatter
Distribution of.
deviation. I don't remember the number, the figure number. One of those figures,
The
bar diagram.
figure one, sir. That is figure one, sir. That is distribution, right skew distribution. You are telling.
One of those. I didn't see the number, figure number. I mean, I thought it was a little too high with considerable overlap between the groups being compared.
Okay, sir.
Anyway, you must have done the analysis, isn't it? So,
Okay, sir.
Okay.
Any other comments from Dr. Needu or Dr. Madhu?
No, sir, not from my side.
No, sir.
Okay, then we'll move to the next presenter. Thank you, Dr. Dinesh. We'll move to the
Thank
next
you, sir.
one.
Thank you, sir. Thank you,
Okay.
sir. Thank you, sir.
Dr.
Thank you, sir.
Harbir Kaur, she is around. Yeah, Dr. Harbir Kaur. Over to for digital tools and devices in heart failure care. Can you share your screen and go ahead?
మాట్లాడదు గ్రీషమ్మ కాసేపు మాట్లాడుకుంటుంది.
Number, can you tell me the abstract number, please?
It is number 2, Harbir Kaur, digital tools and devices in heart failure.
Yes, sir. I'm trying to share the screen.
Vinay, can you help her, please?
Yes, sir. Ma'am, what is it happening?
I have just clicked on the share, but screen sharing option is not coming here.
Once you click on share, you will have to press you select your presentation. Is your presentation open?
Please give me some time.
I have your PPT. Shall I?
Sir, yeah, can you please share that because it's not possible from my side. There is some technical issue.
Okay, Vinay, you can share the PPT and you can move it according to her advice.
Yes, sir. You just tell me when to move it or move this.
Sure, sir, sure. Yes.
Yeah, you can start,
First
Dr.
of,
Sandesh. You can reset the timings also. Yeah.
first of all, good evening to all the respected chairpersons and the colleagues. I am Dr. Harbir Kaur. My presentation today is based on the abstract title Digital Tools and Devices in Heart Failure Care, Insights from Inpatient Admissions in Resource Limited Setting. Can we move to the next? Heart failure, as we know, it's a major public health problem. It is associated with significant morbidity and mortality. It often has an unpredictable clinical course. It leads on to recurrent hospitalizations, which causes heavy burden on the patients in terms of monetary costs and psychological impact also, as well as it strains the healthcare system. Next slide, please. Next slide. As we know that the world is moving rapidly towards the digitalization, so is happening in our healthcare field also. We are coming up with the digital devices. Multiple devices are available currently in the heart failure management. It ranges from basic devices to some advanced technologies, from invasive technologies to non-invasive ones. They have a great potential to improve the early detection of clinical deterioration in heart failure patients. Can we move to the previous slide? The slide with the images, third number. Yeah. In this slide, as we can see, various devices ranging from basic images, the slide with the images. Yeah. We can see in this slide that this slide is depicting various devices ranging from basic devices like pulse oximeters, smartwatches, weighing scales to some advanced level of devices in the form of adhesive patches like Zoll patch, CO patch is there, remote dielectric sensing system is there, wearable holder monitors are there. And apart from these devices, we have certain AI and machine learning based digital devices with us in the form of smartwatches. Smart stethoscopes are also coming up. We have implantable loop recorders are there, ICDs are there, and Cordella cardiomems are there, uh, which help in assessing the fluid status of the lungs in heart failure patients. And we also have some portable ECG devices as well. To name a few, like core devices there, PM Cardio, Williams, AI ECG platforms are there. And recently, Indian government has launched digitalization in healthcare field as well. One of those is the Ayushman Bharat Digital Mission, which includes healthcare facility registry and professional registry. And we also have telemedicine. For the telemedicine, we have developed this app as shown in the picture, eSanjeevani. It is launched by Ministry of Health and Family Welfare for the remote monitoring of the heart failure patients, which will help in detecting the early symptoms of the decompensation to prevent the further complication. Can you move to the next slide, please? So we know that a lot of digital devices are available with us, but despite the proven efficacy of these digital tools, their implementation in resource-constrained settings remains suboptimal. This leads on to advanced clinical presentation and increased morbidity. Next slide, please. Our study objectives were to evaluate the clinical characteristics, inpatient outcomes, and to identify the critical windows for digital health integration. Next slide, please. We did a retrospective observational analysis on anonymized inpatient records. 30 adult patients were taken as a sample and various variables were assessed like demographic profiles, heart failure phenotypes, ICU utilization, length of stay, in hospital outcomes to map the clinical trajectory and course of the cohort. Next, please. Analysis of this cohort of 30 patients revealed that majority of the patients presented with acute decompensated heart failure and advanced disease with multiple complications in the form of acute kidney injury, congestive hepatopathy, pleural effusions, and even cardiogenic shock. There were high rates of ICU utilization and prolonged inpatient stays were observed. The frequency of recurrent admissions and delayed clinical presentation, it underscores significant deficits in outpatient surveillance and early stage monitoring, which could have prevented the progression of the disease to another stage. Next, please. In conclusion, high burden of acute decompensation and resource-intensive care highlights a critical need for proactive management. There is a need for integrating simple, cost-effective digital tools like home-based weighing scales, pulse oximeters, and digital BP monitors, and in selected settings, ambulatory blood pressure monitors. It provides a scalable solution to facilitate early detection and reduce the avoidable hospitalizations. And these strategies are vital for optimizing outcomes in charitable healthcare models where resource allocation is the primary concern. Thank you, sir.
Thank you, Dr. Harbir. Over to the judges for the questions. Biju?
Thank you, Dr. Kaur. It's interesting, actually. So you were using whether patient level monitoring will help in monitoring heart failure patients and all. So what are the, given you another chance, in what way you will try to improve this, the methods?
Definitely, sir, we will try to integrate these digital devices into our routine clinical practice. So as I am working in a charitable hospital, so I will look forward towards the simple and cost-effective tools. As I mentioned in the slides, like digital BP monitors can help, pulse oximeters can help, and weighing scales can also help in detecting the early.
Yeah, Dr. Kaur, actually, some ways actually we can improve this. Is like you are just 30 patients. So who are all those 30 patients? Whether there are newly diagnosed ones or their own treatment, and how did you select them? Actually, whether there is
Sorry, sir, voice is breaking.
Abstract, actually.
Vijay, your voice was
voice.
break. Can you
No, I
repeat
was
the
telling you
question?
that-
I think you can put off your video. There is some connection problem. So your voice was
Yeah,
not. Yeah.
is
Better
it
now.
better
Please go
now?
ahead.
Yes, sir. Yes.
Yeah. Actually, I was wondering, the 30 patients who you selected, from where they are
Yes.
coming, and whether they are fresh cases or they're already on treatment, and how did you choose them, and what's the potential of, because only patients who can monitor that BP and share that with across these platforms, they're only selected. No, actually there could be a issue with the selection. What we call selection bias could be there. No, and
Yes, sir.
and patient also, if you can categorize them into what stage of cardiac failure, and that are all missing in your presentation and in your abstract.
Yes,
If you can incorporate that, it will be good.
yes, sir. Sir, majority of the patients who presented, they were chronic cases of heart failure who presented with acute decompensation in our setup. So sample size, I agree that it was small, and it is one of the limitation of this study. And as it is a single center study only, so we need further studies on this topic, and we can keep the sample size long for our further studies.
And next time, Dr. Kaur, actually you have to think about in using what platform you share the patient data. Like as per the EMR regulations of Government of India, actually we have to be very careful in sharing the data through social media and all. You may have to use some very safe and it should be shared in a very safe way, like some confidential schema should be used.
Yes, sir, definitely. Sir.
Okay, thank you.
Any other comments?
Dr. Kaur, I just want to ask you something. Should you not factor in the multiple variables?
Sorry, sir?
Should you not factor in the very many variables?
Yes, sir. Variables we assessed are like demographic profiles of the patient and their clinical characteristics we assessed, and the ICU utilization and the length of stay in the hospital. These were different variables which we assessed, and I kept it.
I mean, comorbidities, all of that you factor in?
Yes, definitely. Majority of them were having diabetes mellitus, hypertension as a comorbidity, and some of them were even suffering from coronary artery disease.
Okay.
Yes.
Dr. Needu and Dr. Madhu, any comments?
No, sir, we can proceed to the next speaker.
Okay, so we'll move to the next one. Dr. Diksha Singh, polyadenylation dynamics in cardiac hypertrophy, canonical versus non-canonical pathways. Over to Dr. Diksha. Dr. Diksha, are you around? She's not. So then shall we move to Dr. Naveen? Dr. Naveen, are you
Hello.
ready?
Hello.
Yeah, Dr.
Can you
Diksha,
hear
you
me?
can start. Yeah,
Yes. Okay. Let me share my slides, sir.
yeah, please. Yeah, please stick to the time. Please don't exceed the
Yeah.
time. We are running
Yes.
short.
Yes.
Yeah.
Hello. Good evening to all. So the today's title
We
of my
cannot
talk is
see
the
your slides.
We
polyadenylation dynamic
cannot
in
see.
cardiac
We
hypertrophy.
cannot see your slide, Dr. Diksha. We cannot see your slides.
Okay. One.
Yeah, now we can see. Yeah, start.
Oh. Okay. Thank you. Good evening, all. So the title of my today's talk is polyadenylation dynamic and cardiac hypertrophy, canonical versus non-canonical pathway. So it is basically we want to see the 3' end polyadenylation of the RNA in the cardiac hypertrophy. So just I'll let you know something about the 3' polyadenylation. It is a post-transcriptional modification that occurs after the generation of the RNA, then it goes to mature the RNA. So there are two polyadenylation complex. One is the canonical complexes, and the another one is the non-canonical star pep complexes. So there are when these RNA are going to mature, it undergo to the polyadenylation, and there are some specific sequences. We call it the cis regulatory sequences. Those are recognized by the many transacting factors. Those play an important role in the polyadenylation. So these two complexes are different from each other because the canonical one do the polyadenylation by the polymerase, but the non-canonical one do by the star pep. It is another non-canonical targeted. So next we want to see what is the role. So this non-canonical 3' polyadenylation complexes actually do the polyadenylation of the RNA. Those are mainly responsible for the cardiac hypertrophy, heart failure, and also what is the cardiac hypertrophy? It is a disease condition where heart's cardiac cells gets increase in the size. Because of that, the left ventricular region goes shrink, and there are many different metabolic pathways those change undergone. So specifically, cardiac hypertrophy is usually physiological and the pathological. In physiological, it is a reversible hypertrophy, and usually it occurs during the excessive exercise and the pregnancy. But when we talk about the pathological hypertrophy, it is not a reversible hypertrophy, and there are usually increased fibrosis, insufficient angiogenesis, and there are many pathological expression. Those change. Fetal gene programs, those change. So what is our when we talk about the star pep from our labs, only from our groups, there are a research already, like star pep is an anti-hypertrophic factor, means when there is a down regulation of the star pep, it causes the hypertrophy. But what about the another complexes, that is the normal canonical complexes? What is the role of that complex in the hypertrophy? So our hypothesis is like that there is some different processing factors that play role in the hypertrophy, and how in absence, how it is doing the polyadenylation. This is our hypothesis. So I'll go to my result path. So first we check the mass spec data of the canonical and the non-canonical one. There we found there are some specific processing factors. After that I confirmed that data with my immunoprecipitation data. So this is the flag star pep IP data. Here it is showing WDR33, PAP alpha, CSTF64, and tau. These are some specific processing factors only present in case of the canonical one, but this is absent in the non-canonical one. When we talk about some different subset of the processing factors, star PEP, RBM10, PIP kinase alpha, this is only present into the non-canonical, but not in the canonical one. So there are specific processing factors present in both canonical and the non-canonical one. After that, we were having the transcriptomic data of this. So when we compare the WDR33 with star PEP, there are many very less genes. Those are similar. But when we'll see about in between, there are higher genes are similar in between. So what we want to see next, we want to see the effect of the both complexes on their targeted genes. So for that, we have taken some processing factors, and we want, upon the knockdown of these processing factors, we'll do the expression of the targeted gene. So when we knock down the processing factors of the canonical complexes, I noticed GATA6, GATA4 is the pro-hypertrophic expression. This is upon the down regulation of these factors, it is going down. But those are the non-canonical target. It's not changing. Same I checked on the RNA label also. But when I knock down the non-canonical processing factors like a StarPep and RBM10, there was a no down regulation of the GATA6 and GATA4, but other non-canonical target like NQ1, HEN2, and HO1 was the down regulated. Same I checked with the RNA label also. Next, we want to move the hypertrophy. Like we want to see these processing factor in the hypertrophy. So for the hypertrophy, we are using the three models. One is the H9C2 cells. Those are the red cardiomyocytes. AC16, those are the human cardiomyocytes. And the animal, those are the Vistar red. We induce hypertrophy by the induction of the isoproteinol. And after that, we will check all the processing factors like ANP, VNP. Those are the upregulated upon the hypertrophy. And SARCA, these are the downregulated. And for the Vistar red, we do the echocardiography of the red before and the after of the treatment. And then we confirmed with the FSEF, like animal has gone under the hypertrophy condition and not. After that, we have checked the expression of the processing factors in these upon the hypertrophy. So WDR33, CSTF64, and those processing factors are upregulated upon the hypertrophy. When we talk about the some other like StarPep, RBM10, those are the downregulated upon the hypertrophy, and other factors are similar. Other factors are similar in both the same. So that means the pro-hypertrophic and anti-hypertrophic genes are distinctly regulated by the WDR33. Means WDR33 or the non-canonical one regulated the pro-hypertrophic genes, and the non-canonical StarPep is regulated the anti-hypertrophic genes. Thank you.
Thank you, Dr. Diksha, and we'll move on to the judges, Dr. Shivakumar.
Yeah,
Dr.
Dr.
Madhu and
Diksha,
Dr.
I just want to ask you something.
Yes.
Can you hear me?
Yes, sir.
Yeah, we can hear you, sir.
Okay. Now, one thing is, how do you relate all these changes to disease severity?
Sir, I couldn't hear you. Just reply the question. Just repeat the question, sir.
Should you not? See, when you're looking at a parameter, when you look at such parameters, you need to relate, to the degree of severity of the pathology, isn't it? Condition, the disease. Have you done that? Degree of severity of the disease.
No, sir. No, sir, we have not checked that because
these are all molecular events. These are molecular events that will change with severity.
Yes.
So, isn't that an important parameter that you should look at? At what stage of severity did you undertake the analysis?
Those are severity. Actually, we haven't checked, sir.
That is important because it will change with time. Number one. I mean, early versus late stage, after onset of hypertrophy and so on. The other thing is, why did you choose GAP-DH as your loading control?
Sir, because those are the Western, and I choose the GAP-DH.
No, that's what I'm saying. For Western, why did you choose GAP-DH? Why not something else?
Because, sir, when we see like if we'll choose GAP-DH.
I'm not sure that GAP-DH is the best loading control here. When there are so many other options. I'm not very sure.
Okay,
but
sir.
I think you give some thought to it, GAP-DH.
Okay, sir, I'll see.
There are so many other loading controls. Yeah, that's it from me.
Yeah, there are many others, beta-actin and all, but in case of the hypertrophy, I can't use as a alpha-actin because it also increases. So this was another I choose the GAP-DH.
I'm not very sure about this, GAP-DH. Anyway.
Okay, sir, I'll take it as
some thought to it.
Suggestion. Yes, sir, I'll check.
Yeah.
Dr. Needu? Madhu and Needu?
Yeah, one quick question. You said the canonical pathway regulates the hypertrophic genes, and the StarPep regulates the anti-hypertrophic genes. So in the progression of hypertrophy, actually a balance of both this required, right? Reduction of hypertrophy as well as upregulation of the anti-hypertrophic. So in the progression of heart failure, which one do you think both the pathways should equally have a role?
Yes, ma'am. If
both
any
canonical and non-canonical should have an equal role.
Yes, ma'am. This is what my study suggests. If any of the complex is going up and down there, it will cause the heart failure. So for a healthy heart, there should be a proportion of the canonical and the non-canonical gene expression that make it a healthy heart.
Okay. So, I mean, your study says that both StarPap as well as the canonical have an equal role?
Yes, ma'am.
Oh, okay.
Hi,
Thank you,
Diksha. I have a quick question.
Yes, sir.
Yeah, so if you add another parameter like the gene mutations which cause HCM, so do you think this pathway will be same or it can be alternative or?
Sir, in this case, sir, I have to look like which gene and how important is the mutation and the gene for the hypertrophy case. If it is a very important gene for the hypertrophy, then obviously there will be some different mechanism to check that. It
Yeah, the
depends.
question is whether are you planning to look such things?
No, sir, we are not looking for the mutation.
Okay. Yeah.
Oh, thank you, sir.
Thank you. Thank you, Dr. Disha. We'll move to the next presenter, Dr. Naveen Sukumaran Nair, Guideline Directed Medical Treatment of Heart Failure at a Tertiary Care Center in Central Kerala, a clinical audit. Over to Dr. Naveen.
Good evening,
Dr.
sir.
Disha, you can unshare your screen.
Yes, sir.
Yeah.
Good evening, sir. I am Dr. Naveen Sukumaran Nair. I am a consultant family physician and chief operating officer at St. Thomas Hospital, Chitipura. I'm currently sharing my screen. I hope the screen is visible enough to everybody.
Yeah, can you make it full screen?
Yes, from beginning. Yes. Right. Guideline directed medical treatment of heart failure at a tertiary care center in Central Kerala, a clinical audit. This shall be the contents of my presentation today. I shall be briefing on the introduction, the study rationale, methodology, and a brief about what do you mean by the guideline-directed medical treatment. I'll be going through the results, giving up certain recommendations and also my conclusion. Heart failure remains a significant health challenge in Central Kerala with rising prevalence due to multiple socio-demographic factors. And guideline-directed medical therapy, as indicated in the year 2022, has been proven to improve survival, decrease hospitalization, and enhance the quality of life in heart failure patients. The rationale is there are a lot of existing gaps in adherence to guidelines, even in spite of documented evidence, which has got a huge impact on patient outcome, and hence there is a need for institutional evaluation at all tertiary care centers, because at those centers, patients with heart failure come as the last beacon of hope. And institutional assessment helps to definitely identify the specific areas for improvement and also aligns our protocols and we will be able to elevate our care standards. These were my objectives of this study. The first primary objective was to assess the adherence to GDMT in patients with heart failure at the selected tertiary care center here in Central Kerala. And my secondary objectives were also to evaluate utilization rate of individual GDMT components, to assess the dose optimization of GDMT, and also to identify clinical and non-clinical barriers. The methodology was this. The study was conducted at a tertiary care teaching hospital located in Central Kerala, and the entire period of this study was for 12 months, during which all the eligible admissions with a diagnosis of heart failure were reviewed. This study was a retrospective descriptive clinical audit aimed at evaluating the adherence to GDMT, and the study population included a total of 200 adult patients aged greater than 18 years and admitted with a diagnosis of heart failure. The patients were recruited using a consecutive sampling method, which made it easy for us to look into all the patients during the specified time period of 12 months. The sample size was calculated using the Cochrane formula, and the total sample size had come up to 200 patients. The inclusion criteria were all the adult patients aged 18 years and above, and also the patients admitted with a clinical diagnosis of heart failure, along with availability of the echocardiograph assessment of the left ventricular ejection fraction, and patients receiving inpatient or discharge on pharmacological management for heart failure were included. The statistical analysis was done through using the chi-square analysis, and ethical clearance was also obtained. This is in short about the GDMT as indicated in 2022 by the American Heart Association. It includes a combination treatment with ACE inhibitors, beta blockers, mineralocorticoid receptor antagonist, and additional therapies as required by individualistic care. These were our main results. The most of the patients, the majority of the patients, 35% belong to the age group 18 to 40 years, and above 60 had constituted almost 15% of our entire population group. We had a strict male predominance with 55% of patients belonging to the male gender, and almost 60% of them were in the employed category, and 65% of our patients belong to an urban area which we basically serve to, and the proper treatment for comorbidities was received, unfortunately, only in 40% of the cases. And as far as the heart failure phenotype was considered, we can see that HRR-EF was seen in less than 40% of the cases, and HFP-EF was seen in 13% of the cases. Dose optimization was an important factor which we looked into during the entire study, and we can see that 38% of the entire population had got more than 50% of the target dose that was achieved, and 14% of the patients were in a situation to who were unable to uptitrate the dose. GDMT, all 4 agents were also observed in very less numbers when compared to one agent. One agent was followed up in more number of cases. We can also see that these were the associations that we looked into. Age group and financial constraints were really 2 important values which were attributed to the GDMT following up. Association with GDMT and clinical factors also showed us that NYHA classification was seriously linked to the GDMT adherence. These are the 2 points that I would like to ensure during the course of our study. In hospital mortality rate, a total of 8%, in that only 2% of the patients who followed GDMT were pushed into mortality, and readmission rates also were considerably brought down in case of patients following GDMT. These were the main SWOG analysis that we have. The use of contemporary guideline definitions were the strength of our study. The weakness was that we could not look into the optimized therapy after that, and recommendations for further analysis with multiple center collaborations are also suggested as a part of our study. I would like to thank you for the situation given to me in order to present the key findings of my study. Thank you so much.
Thank you. Over to Biju for his comments and questions.
Thank you, Dr. Naveen. It's interesting. Actually, I was wondering, you have selected 200 patients.
Yes.
Out of how many patients? And when did you enroll the patient? These are all missing in your thing.
Thank you, sir. Sir, I had mentioned that ours was a retrospective study, sir, and it was done for the last 12 months. We have had more patients coming into the cardiology department of our hospital, but still these 100 patients were taken with those who came with a confirmed echocardiography diagnosis of heart failure, and also who were ready to follow their continuous treatment with us. A total number of almost 500 to 600 patients were enrolled, but only 100 people were continuing our treatment with us for a long period of time.
Yeah, good. Actually, being a hospital-based study, when you're doing the sample size estimation, you have to incorporate that finite population correction. So now what you use is population-based sample size estimation. Ideally, you should use the finite population correction because we know the number of the patients who are coming. And second thing, I was wondering, like the mean age of your study population is around 45
40s, in 40s.
Okay. Is it the usual pattern in heart failure, or
no, sir. Actually,
somewhat younger patients?
Yes, sir. Thank you for the question, sir. Sir, actually, our population, our hospital serves to people from 18 years till almost up to 70 years. But unfortunately, most of our patients who come to our hospital, they belong to NRI category. So most of them, they would either be visiting their children, living abroad, and they would be going back, and for continuing of treatment would be happening at some other places. So we got only those people who are resident Keralites at this point of time, and they were actually belonging to this working age group of 40s and above. Ideally, it should have been the reverse. It was also a wonder among us, but unfortunately, most of them, they chose to go be with their children abroad.
Yeah. Dr. Naveen, one more issue is like this is a teaching hospital.
Yes.
And who are all seeing this patient? Actually, I was thinking about what could be the part of the clinician. Actually, this adherence to guidelines, actually, usually the clinicians are prescribing. How many clinicians were involved, and whether have you seen any change in the adherence pattern with
Yes.
respect to the profile of the clinicians?
Yes, sir. Sir, actually what happens over here is, some part of this treatment will be initiated by the cardiology department and later it will be continued at multiple other departments, especially the Department of General Medicine. So if the follow-up also takes a turn because it is very difficult to get the appointment of the cardiologist. So what happens, half of the time the follow-up happens with the general physician who would be the first point of identification. So whenever it is happening with the cardiologist, the follow-up and adherence is quite good. Whereas when it comes to the general medicine or
You
case,
could have made it very explicit. You could have made it very explicit in the presentation.
I will keep that in mind, sir. Definitely, thank you for your suggestion, sir.
Any other comments? Shall we move to the next presentation by Dr. Mohsin Raj? Over to Dr. Mohsin for his crossover study of P1 2.5 exposure and heart failure hospitalization from the National Heart Failure Register.
Good evening, sir. Sir, are my slides visible?
Yeah,
And
yes,
am I audible?
your slides are visible. Please go ahead.
Yeah. Good evening. I am Dr. Mohsin Raj Mantu from All India Institute of Medical Sciences, New Delhi. I thank Dr. S. Harikrishnan, sir, for the opportunity because the study is essentially based from the data on National Heart Failure Registry, for whom sir is the principal investigator. I would like to thank other collaborators from IIT Delhi and my chief guide for this work, Professor Ambuj Roy. The title of this work is a case crossover study of PM 2.5 exposure and heart failure hospitalization. Yeah. Sorry. So we know that heart failure is a leading cause of hospitalization across the world and including India. And ambient fine particulate matter pollution, PM 2.5 levels, it's a recognized cardiovascular trigger. It triggers acute MIs, it triggers arrhythmias, it triggers heart failure events. But most of the studies, including the studies of heart failure, come from high-income countries where the PM 2.5 values are actually low as compared to India. I'm quoting one landmark meta-analysis published in The Lancet in the year 2013, where each 10 mics increase in PM 2.5 level was associated with a 2% increase in heart failure events. Now think of India. We have a huge population of chronic heart failure patients, and we have a very high PM 2.5 value levels. So that's the essence of that's the need of this study. And the objective of the study is to evaluate the association between short-term ambient PM 2.5 exposure and hospitalization for acute heart failure in India. This is the time-stratified case crossover study design, quite aptly designed for such acute events like acute heart failure and triggered by such acute triggers like PM 2.5 exposure. In this study design, each patient serves his own control. And therefore, it automatically controls for things like age, gender, socioeconomic factors, other demographic variables, and other clinical variables like heart failure severity or use of utilization of guideline-directed medical therapy. And not just that, the time-stratified nature essentially controls for changes with seasons or even the days of week affected by the study design, essentially. As I mentioned, this is based on National Heart Failure Registry, which was conducted in 53 hospitals across 21 states in India. Now, for this particular analysis, we've just included the first hospitalization with the registry centers. Well, the registry total includes about 10,000 patients. But for this analysis, we have data on 8,081 patients for which PM 2.5 values were available. And we thank the IIT Delhi team for this, the assessment of PM 2.5, because the assessment of PM 2.5 was based on satellite-derived data. And the data is validated, previously published, has a good spatial resolution, 1 kilometer spatial resolution. And what we did was the pin codes of patients' residences, they were converted into longitude and latitude geocodes. And then we have this 1 cross 1 kilometer spatial resolution PM 2.5 level data available for these geocodes. And that's how we calculated the PM 2.5. We also adjusted for other meteorological variables like temperature and relative humidity. So the analysis was done using conditional logistic regression. We used the distributed lag model, understanding that there may be a lag between the exposure to PM 2.5 and heart failure decompensation. We examined short-term exposure over a lag period of 0 to 6 days, where day 0 refers to the day of hospitalization. And similarly, day 1 would be 1 day preceding hospitalization, day 2 will be 2 days preceding hospitalization, and so forth. So our primary analysis was cumulative short-term exposure using a distributed lag model. And we estimated odds ratios per 10 mics increase in PM 2.5. These are the general population characteristics: mean age of 60 years, 65% about HFrEF, 72% patients had ischemic heart disease as the cause of heart failure. As seen in the table, the average values of PM2.5 actually varied widely. The average value was 54 mics per cubic meter, but the values could be as high as 105 in North India, could be as low as 31 or as low as 29 in Northeast. We found that each 10 mics increase in PM2.5 was associated with a 1.85% increase in the odds of heart failure hospitalization, and this was strongly statistically significant. To the left is the lag-specific association, where we find that this odds ratio was highest and the association was strongest at the lag period of 0 to 1, which supports the acute triggering event. And to the right is the spline curve, the exposure response curve, where we find that the association is almost linear. And the plateau towards the extreme of exposure is likely in the wide confidence interval because of sparse data at such high exposures. We did some subgroup analyses. They were all exploratory, but the effect, the association with the PM2.5 exposure and heart failure hospitalization was seen more in women, more in older people older than 60 years, and more in HFpEF than HFrEF. Why this matters in India? Because, see, the relative risk is similar. We report 1.85% increase. The previous meta-analysis reported 2% increase. But the absolute impact is likely much larger because we are exposed, the Indian heart failure patients are exposed to much higher PM2.5 values, often exceeding 100 mics per cubic meter. The strengths of the study are that this is a national multi-center registry, the study design, a robust time-stratified case crossover design, and high-resolution exposure data on PM2.5 exposure. The limitations are we did not have co-pollutant adjustments. We did not have data on, say, other pollutants like ozone or nitric oxide or sulfur dioxide and things like that. Thank you.
Viju, please go ahead.
Yeah,
Shivam,
thank you, Dr. Hello, am I audible?
Yeah, you are
Yes,
audible. Please
Yeah,
go
will you
ahead.
carry on?
Yeah, Dr. Mushin, yeah, interesting study actually. I congratulate you for this work.
thank you.
I was wondering actually when you were doing this crossover analysis, have you collected information on undercurrent infections and in what way they affect the outcome?
So as I mentioned, in this study design, the case day, we have case days and control days. The person is the same. So this study design by default takes care of all other time invariant variables. So it doesn't matter what the ejection fraction of that patient was. It doesn't matter what the therapy of that patient was. It doesn't matter what how many GDMT agents he had. What was the trigger of acute heart failure? Those things don't matter in the study design. What the study design does is that we have a case day, that's the day of hospitalization, and we have the exposure on that day. And we have the control days and we have the exposure on those control days. And using the conditional logistic regression, we just estimate the odds of having exposed in the control days and the odds of having exposure on the event day. And that's
thank
the
you.
thing.
Thank you. You are suggesting that it will be taken care of by the very nature of the design. And second thing, actually, like some of the recent analysis on environmental pollution says like some of the work with IAC Bangalore and all. It's not the ambient air pollution levels, but it's the anthropogenic component of that. Because during COVID times, actually, they could see the baseline thing and all. So it's the anthropogenic component. If you try to attempt to see the anthropogenic component, because that varies from place to place, no? That would make your study more robust.
Can you elaborate? We did one sensitivity analysis excluding patients who were admitted during COVID-19, and the associations were significant. We're actually working on this paper for a journal, and the journal editors actually advised for that sensitivity analysis. But the anthropogenic, I'm not sure what exactly it refers to.
During COVID times, actually, there were not much locomotion or pollution due to these vehicles and all. No, and they have looked at the pollution levels in India and across European nations and all. And they found that actually in India compared to European nations, we are having our incurrent PM levels are higher than that of European nations. And whenever we are going beyond this baseline, actually that is what is causing lot of ill effects. Otherwise, our population will be tuned towards the the prevalent or the ambient air pollution levels here and all. So you can just explore it. That will make your work more robust. And one more thing, actually, now this PM1 is also coming up. And if you can get that data, and it has more studies have seen that it's more correlated with the non-communicable diseases person.
Yes, the ultrafine, as you're mentioning, because supposedly directly enters the circulation, like from it penetrates the pulmonary capillaries and straight away goes into the vascular endothelium. But our data is limited by the satellite-based information that we have. The model is calibrated for PM2.5. If there's a way to find co-pollutants, if there's a way to find, well, definitely, this is an important point. We'll get some good data. We'll try.
Dr. Shivakumar.
No, I don't have anything to ask. Vijay Soman has, come up with some pertinent questions and points.
Dr. Madhu or Dr. Needu, anything?
No, sir, I can go ahead.
So thank you, Dr. Mohsin. We'll go to the last presentation. Dr.
Thank you,
Santosh
sir.
Kumar on resistant-like molecules in RV failure, RV dysfunction, and RV failure. Over to Dr. Santosh.
Thank you, sir, for giving me the opportunity to present my research work here. So I would like to share my screen here. So please let me know if it is visible to all of you.
It's visible. Can you make it full screen?
Yes, sir. Just a minute. So I'm Dr.
Go ahead.
Kumar, going to present my work in right ventricular dysfunction and failure. So basically, in this work, I have used the pulmonary hypertension model, that is monocotyledon induced PH model, as well as the hypoxic induced monocotyledon model, as well as I have seen the role of registrin, means expression of registrin in the scleroderma associated pathological hypertension patient. So not going much into the brief introduction about that. That is very common to all of the presentation, that cardiac failure is a very important cause of death. So here I'm mostly focused on, my work is mostly focused on the registrin-like molecule, that is realms expression, which is a pleiotropic cytokine, which is proliferative, pro-inflammatory, pro-fibrotic, vasoconstricting, and chemokinetics. So in human, its isoform is known as human registrin, and its rodent homologue is known as registrin-like molecule alpha. It is also known as hypoxia-induced hematogenic factors. So there are several names for this. Also, the found in inflammatory zone molecules, phase molecules, because their expression during the inflammation, expression during the hypoxic conditions. So that's why they are named like this. So my data suggest here that the real alpha molecule, which modulates the calcium signaling pathway, immunomodulatory pathways, that is playing the critical role in the pathogenesis of the cardiovascular dysfunction. So this is my first slide representing the data where I have measured the expression of the real alpha molecule, which is a rodent homologue in case of rats and mice. So here we have find that the expression of the real alpha in case of hypertrophy as well as the heart failure condition, it is more in the earlier risk factor, that is measured in terms of real red color antibody. So it is more in the case of right heart, also in the case of left heart, but in the case of more in the hypertrophic case, means it is expressing more in the earlier stages of the cardiovascular disease risk factors. And in the heart failure, it is not so much recognized as compared to earlier time points. Its expression is also visible in the scleroderma associated PH patients. So that is clearly visible with the arrowhead shown here. So my next data represent that when there is a expression of the, I have also used the one mice that is expressing the human registrin isoform, that is the humanized cardiac mice inhibition registrin mouse. So in that, what we found that when we induce that human homologue of the registrin in the mice, then we found that there is a decrease in the twitch force that is responsible for the cardiac constriction. So in case of myosin heavy chain under the promoter is expressing the human registrin mouse, there is a decrease in the twitch force, and also there is a decrease in cytosolic transient concentration, since calcium is very important for the cardiac contraction. So decrease in the calcium transient concentration was found in my case, which is also supported through the decreased phosphorylation of the protein kinase A, as well as the decreased phosphorylation of the protein A, mitogen protein kinase mice expressing the humanized human registrin mice. So what we found, the increase in the hypertrophy as in case of the increased cardiomyocytes, Fibrosis is also visible in terms of the H&E data that suppose that mice expressing the human resistant isoform is responsible for the cardiac dysfunction. So next slide I have done in the in vitro as well as in vivo that is supported by my molecular work is that REL alpha expression in the hypoxic mouse, when we use the antibody against the realm alpha, we found that there is a decrease in the expression of the HMGB1, that is high mobility group box1 protein. That is a danger associated molecular pattern that express upon the inflammatory condition. So in addition to this, what we found that there is a decreased expression of the ANP and beta-mycin heavy chain, that is the marker of pathological cardiac hypertrophy. So when we use this human resistant mice expressing this human resistant, we also find the decreased expression of the HMGB1 as well as the ANP and beta-mycin heavy chain marker under the influence of the antibody that we have devised. So we found that ethyl pyruvate inhibitor, which is an inhibitor for the HMGB1. So when we use the ethyl pyruvate as inhibitor in the case of neonatal ventricular myositis expressing the human resistance, increased expression of the cardiac hypertrophic marker ANP and beta-mycin heavy chain gets significantly decreased. Also, the cell site gets significantly decreased. So taken together, these data suggest that it has a significant role in the HMGB play a significant role in a cardiac dysfunction. So our antibody is neutralizing its expression and it has a significant achievement in the pathological cardiac dysfunction and ameliorating the pathological cardiac dysfunction. Next, we are focusing on how the calcium channel is important in my study. So what we found that using the calcium channel, that is the nifedipine, which is the blocker of the L-type calcium channel, and I also use the Calhax, which is the calcium sensing receptor channel. So when I use this inhibitor in the in vitro, that is neonatal ventricular cardiomyocyte, we found the decreased expression of the cardiac hypertrophic marker ANP as well as beta-mycin heavy chain. We also found the decrease in when we use the same experiment in the case of using the overexpressing the HIM by the adeno-associated virus, we found the decrease in the cytosolic concentration of the NFAT-C3, while the increased concentration of the nuclear cytosol under the presence of overexpressing the HIM. So that also leads to the expression of the MAP kinase pathway, which is significantly restored by using the overexpressing the HIM. So we found that NIF as well as Calhax, which is the blocker of the calcium signaling, is very important. Next, we found that when you use your siRNA against the HIM, it decreases the expression of the hypoxia inducible factor 1 alpha. So that is also decreasing the pathological cardiac hypertrophy marker, that is ANP as well as beta-mycin heavy chain, and it also decreases the cell surface size. So taken together, our data suggests that in case of hypoxic mice, there's decrease in the pulmonary acceleration time upon the pulmonary endothelial thickness, and also the right ventricular systolic pressure, as well as the Fulton index measured by the expression of the right ventricle upon septum thickness. So, and also the monocotyledon model show significant survival upon the using our antibodies. So taken together, our data suggests that human resistant antibody playing a significant role in ameliorating the cardiac dysfunction in the pH-associated model, as well as STAT3 signaling. And we also are looking for the mitochondrial binary genetics that play a significant role in a cardiac dysfunction. So with this, I would like to acknowledge the colleagues like the Dr. Kingling from the Johns Hopkins, as well as Professor Roger A. Jones, which is PI of my all this supported work from the Johns Hopkins University, USA. So I would also like to thank the Sri Chitra Trinal Institutes of Medical Science and Technology, ICMR, as well as the Heart Failure Association of India.
Thank you, Dr. Santosh. We'll move on to the question answer session. Dr. Shivakumar, sir, please.
Just one small question. You were focusing on RV dysfunction, isn't it, in PH?
Yes, sir.
So how do you, what do you think will happen in LV dysfunction? Do you think such things you might find there also resistant?
So I have also used a separate model for the TAC model, that is transverse reconstruction model.
What did you find there? Similar findings or?
So in that case also there is a size increasing in the same pathological marker, that is the ANP as well as beta-mycin heavy chain. So changes were similar to that.
So it's not RV specific.
RV specific in case of hypoxic model, but when I use the TAC model, which is the LV specific model, so in that case, molecular markers were near about the same. But RV specific marker, when you look for, then I look for the Fulton index, which is the measurement of the right ventricular thickness upon.
In your hypoxia, sorry for interrupting. Hypoxia studies, what was your model? Was it in vitro or animal?
Yes, sir.
For your hypoxia studies, did you have in vivo or in vitro?
In vivo,
I see.
In vivo in the HD rat, sir.
Okay, right. For hypoxia.
Yes.
Okay.
And the scleroderma associated patient that we have seen also the expression of the HIMF, realm alpha, whatever you want to say. We also find expression in the SSC associated PH patients.
Dr. Needu?
Well, I just wanted to, good presentation. I wanted to ask, you said this molecule or the signaling has role in fibrosis, hypertrophy, calcium signaling, calcium
Equal role means,
contractility.
ma'am?
I mean, you have actually shown its role in almost like fibrosis, hypertrophy, calcium signaling, and G4 alpha. So we did not get a real right now it looks like, it has in almost every process of hypertrophy and associated pathology. So how did you correlate to almost all the pathologies related to this?
So actually, when you talk about the hypertrophy and fibrosis, these are the early risk factor. So when you go for the advanced, as I mentioned in my first slide, that data wise, its expression is more in case of the early risk factor. So when it advances in the advanced heart failure stage, then its expression get decreases because it is the cytokine, pleiotropic cytokine. So it expresses more. So of course the molecular signaling is the most of the some molecular signaling activates earlier, some molecular activates later. But since its activation late in the early stages of, it also has some partial impact on the later stage of the cardiac dysfunction also. So that is visible in my clinical data, arterial hypertension time upon the pulmonary ejection fraction time, and also the Fulton index. So that also shows its expression in the latter stage of the development, but expression is more in the early stage of development, and which is crucial for the activation of those signaling pathways.
Dr. Madhu, any comments?
No, sir, I think, yeah.
Okay, so thank you everyone for the presentations and the judges for the questions and the comments. So now the results will be announced tomorrow at 8 o'clock once the sessions are over. So please join around 7:30 to know the results, or you can join the whole program and see hear about the results. Now we move on to the inaugural ceremony. So I invite Dr. Jimon, Professor C.C. Karta, Dr. B.K. Chopra, Dr. Abraham Mann to join the inaugural session. I invite Dr. Jimon to propose the welcome address. Over to Jimon.
Thank you, sir. Good evening, good morning, good afternoon, wherever you are, depending on your location. Very warm welcome to all of you. It's indeed a great pleasure, rather a privilege to welcome all of you to the HF Conflux 2026, a meeting which is dedicated to advancing our understanding of devices and digital tools in heart failure, an area that is rapidly reshaping the way we diagnose, we monitor, and care for patients across the globe. This conference, this Conflux is jointly envisioned and supported by Sri Chitra Tirunal Institute of Medical Sciences and Technology, the Heart Failure Association of India, and the International Academy of Cardiovascular Sciences. We are grateful to these institutions for their continued commitment, their academic excellence, innovation, and collaborative learning in cardiovascular sciences. I extend my respectful welcome to Professor C.C. Karta, our organizing chairman, for his vision and guidance. A special welcome to Professor Hari Krishnan, our organizing secretary, whose tireless efforts have been central to bringing this conference together. The Heart Failure Conflux 2026 is truly international in spirit. We are honored to have with us an outstanding panel of experts from different parts of the world who bring diverse perspectives and deep expertise in heart failure care. A special welcome to Dr. V.K. Chopra, Dr. Abraham Omen, Professor Hilan, Professor Ramakrishnan, Professor Ambuj Roy, Professor Bahel, Professor Bhuvinder Singh, Dr. Lina Stevenson, Dr. Payakini, Dr. Shivanation, Dr. Nagesh, Dr. Neetu, Dr. Madhusudaran, Professor Viju Soman, and many others who have joined online in this conference. Along with all other distinguished speakers and presenters, your presence greatly enriches this meeting without a doubt, and we are grateful for your willingness to share your knowledge and experience. This conference or Conflux also warmly welcomes students, trainees, researchers, clinicians, and colleagues from across the disciplines. Your participation reflects the future of heart failure care, one that is multidisciplinary, technology-enabled, and patient-centered. As heart failure continues to pose major global health challenge, innovation in devices, innovations in digital health, remote monitoring, and data-driven decision-making offers tremendous opportunities to improve outcomes and quality of life of our patients. We hope that the Heart Failure Conflux 2026 will serve as a platform not only for knowledge exchange, but also for meaningful collaboration, critical discussions, and generation of new ideas. I once again welcome all of you to this Conflux, and hopefully we will have a fruitful Conflux this year. Thank you very much.
Thank you, Jimon. Now we move on to Professor Karta for his inaugural address. Over to sir.
Dear Dr. Chopra, the founder president of Heart Failure Society of India, Dr. Uman, the current president, Dr. Hari Krishnan, Dr. Jimon, distinguished speakers and delegates. As many of you know, the annual Heart Failure Conflux is designed for a multidisciplinary audience interested in the management of heart failure. The aim of these meetings is to provide an overview of the current pursuits and emerging advances in heart failure research. The focus of our meetings in earlier years were on innovative strategies in discovery-driven biological research. The theme for this year is distinct. As you know, the spotlight is on the frontiers of medical technology applications in the management of heart failure. In the early years of modern medicine, the only aids for clinical diagnosis were careful recording of patient history, observation and inspection, palpation, and assessing the color, consistency, and smell of phlegm, vomit, urine, and stool. And for treatment, the tools available were flint knives, needles, forceps, scrapers, saws, speculum, cautery, hooks, and props. Two new significant events in the 19th century. One, the invention of the stethoscope by René Laennec in 1816. And the second, William Röntgen's accidental discovery in 1895 that X-rays are useful for the imaging of internal organs, had a dramatic impact in clinical practice. Thanks to the advances in materials science and engineering disciplines, during the 20th century, several advanced imaging techniques became available and were found useful for detailed observations on the altered anatomy of the human body in disease conditions. Almost parallelly, several devices such as artificial heart valves, implantable pacemakers, balloon catheters, and left ventricular assist devices were invented. A variety of new digital and device technologies are expected to change medical management of heart failure in the near future. The emerging technologies include: one, application of artificial intelligence and machine learning in diagnostics, drug discovery, and personalized medicine; two, telemedicine and wearables for remote care and health monitoring, 3 implants employing 3D printing, and 4 patch-based devices to assess tissue fluids. The digital tools for heart failure management encompass those that support screening, prediction of incident heart failure, early diagnosis, developing risk score, treatment optimization, and analysis of electronic health records. Mobile health applications for these are also on the horizon. As digital tools continue to evolve, they are certain to exert great influence on clinical care because they can be expected to establish new ecosystems that support patient care, especially in lower income and middle income countries. How suitable, efficient, and reliable they will be can only be discerned with time. I hope this meeting would provide an opportunity for you all to learn, share ideas, and identify clinical requisites, as well as themes for collaborative efforts for novel inventions. One person would have been extremely happy if he was in our midst today. He laid the foundation for the convergence of medicine and technology in our country. I wish to dedicate this meeting to the memories of Professor M.S. Veliathan. With these words, I formally inaugurate this two-day meeting, and I thank Professor Harikrishnan for extending to me the privilege of this privilege of inaugurating this meeting. And best wishes to you all.
Thank you, sir. Now we will move on to the felicitations. I invite Dr. V.K. Chopra, the founder, president, and the patron of Heart Failure Association of India, to propose to felicitate the meeting. Sir, please.
Thank you, Dr. Harikrishnan, and Dr. Karta. Thank you so much for your inspiring words. For every new device or diagnostic tool or drug that we get in our hands, most of us clinicians don't realize the hard work and the innovations that have gone on behind the scenes in developing those. And thanks to these kind of meetings, we get a ringside view about the tremendous amount of research and the knowledge which is being generated from institutions such as yours and by other colleagues across the country. A few years back, when Dr. Harikrishnan suggested the partnership of Heart Failure Conflux with Heart Failure Association of India, we gladly accepted, and I am privileged to be a part of this particular joint venture. Over the years, this has developed so beautifully. We have learned a lot. I must admit that a lot of stuff that you guys discuss, it goes way above my head. But still, we realize what is the kind of work which is going on and the hard work and the innovations that go. This year's theme is particularly useful because with the advent of artificial intelligence, such new tools are being developed. And as Dr. Karta very rightly mentioned, they're especially useful for a resource-constrained society such as ours in many parts of our country. With that, I wish the conference great success and look forward to listening to the deliberations. Thank you.
Even though it was intended to come before Dr. Chopra's talk, it came little late. Some digital technology, some hitches, but don't worry.
It is developing.
It's evolving. So we will move to Dr. Abraham Umman for his words.
Thank you, Dr. Hari. Thank you all the organizers of this meeting. So I was reminded of Rudyard Kipling, who said in 1889, "The East is East and West is West, and the twain shall never meet." And we all think that the basic research and clinicians or clinical work will never meet or meet very late. But that gap is rapidly coming down, and the twain is indeed meeting. And that meeting is through meetings like this. And the another, like Dr. Chopra said, I can just sit and marvel at the amount of work, original basic research work being conducted in India. And with the rapid evolution of technology, I think things will move very fast, and all clinicians should and will get a very early exposure to the basic research going into the country through meetings like this. So I wish the meeting very best, and congratulations to you once again. Thank you very much.
Thank you, Dr. Abraham Oman. Now I invite myself to propose the vote of thanks. So, respected Professor Karta, Dr. Jimon, Dr. Chopra, Abraham Oman, Uday, I saw Uday also, our Vice President. So, Uday and all the esteemed faculty and delegates and the participants. Heart failure conflux is into the 6th year, and every year we get more and more varying topics, and we get more and more people attending the conference. First of all, I sincerely thank our director, Dr. Sanjay Bihari, who gave full support and encouragement for this program as a personal level and also as a director of our institute. I have to thank ICMR for funding the KRHF program, the Center of Advanced Research and Excellence, which started the program. And now we have also another Center of Advanced Research. And with that, we started the Conflux program and it was running for the last 6 years. We thank Dr. Rajiv Bahel, the DG, and the NCD non-communicable disease team led by Dr. Taliwal, Dr. Meenakshi Sharma, and Dr. Rupa Shivashankar for the constant support and inspiration to all of us. The support for the Biobank and the CARE project is worth a special mention. Dr. CC Karta, even though he's part of the organizing team, is the key person behind the idea and planning of the meeting. Thanks to you, sir. He suggests the theme every year, and it is it is always unique and will be a state-of-the-art topic. Next, I want to express my sincere gratitude to the faculty who are participating from abroad and across the country, sharing their expertise and experience. Many of them are pioneers in their field of research. I thank the faculty. Some of them are joining the discussions at odd times and some very late into the night or early mornings. I thank Heart Failure Association of India for supporting the event by providing the platform and also providing the whole funding for the program. My sincere thanks to Dr. Chopra, founder president, and Abraham, current president, Dr. Uday Jadhav, the vice president, for their constant support, encouragement, and guidance. There are a few people who are working behind the scenes throughout this program to make it a success. I have to thank Dr. Mahesh and Dr. Abhisha, who without their hard work, this program would not have materialized. I also thank all the staff and team in our heart failure projects. I also thank the faculty, the judges, and who evaluated the abstracts. Online meetings are now established as a medium of communications, and our digital partner, Hallmark Events, Mr. Vinay Sheshadri, worked hard to make this program foolproof. We have pre-recorded many of the talks. I express my gratitude also to the press and visual media for covering the event. Last but not the least, no meeting will be a success without delegates. We hope we will have a good number of delegates like last year, and we expect the number to be more. I thank them profusely. Thank you, ladies and gentlemen. Now so the inaugural function is over. Now we'll move to the first session. So the first session will be chaired by Dr. V.K. Chopra, Dr. Abraham Oman, and Dr. Biju Soman. All of them are here. So over to the chairpersons, please.
Thank you, Dr. Harikrishnan. May I invite Dr. Vipin Ramakrishnan to give his talk on big data and machine learning in heart failure management. Very, very important. Dr. Ramakrishnan, over to you.
Good evening, everyone. I'm Vipin Ramakrishnan. I'm a professor of bioscience and bioengineering at IIT Guwahati. I'm also associated with Mehta Family School of Data Science and Artificial Intelligence. I'm thankful to the entire team, Heart Failure Conflux 2026 team, for giving this opportunity to speak to you. The title of my talk is Integrated Machine Learning and Systems Transcriptomics for Heart Failure, Signatures, Cell States, and Upstream Regulators. In fact, the theme that was given to me by the HF Conflux organizers is Big Data and Machine Learning in Heart Failure Management. So I have separated my entire discussion in two sections. In the first one, I will talk about Big Data and Machine Learning. And in the second one, second section, I will talk about our research in finding signatures, cell states, and upstream regulators of heart failure. Once again, I am thankful to Professor Harikrishnan and Professor C.C. Karta and the entire HF 2026 team for this opportunity. All right, let's begin with our theme, Big Data and Machine Learning in Heart Failure Management. Okay, now let's talk about the big data. So what the first question is, what is this thing called big data? So big data actually refers to massive, complex, and rapidly growing data sets that traditional software cannot efficiently manage, process, or analyze. So generally, this big data consists of, we can classify it into three types of data. One is structured, then the other one is unstructured data, and the third one is kind of semi-structured. In fact, they are generated at very high speeds, you see, and for instance, news items published in open digital platforms, they come in at very high speeds. So when we analyze such big data, what we are required to is to keep up with that speed of sorts. Now, from a heart failure research perspective, I will share my thoughts in a question and answer format. Generally, I take my lectures like this, so I'm adopting that thing. So why this big data in heart failure? Because traditional clinical trials often treat heart failure as a monolith. And big data generally allows us to see heart failure as a heterogeneous syndrome. So that is the answer of why big data. And what do these data contain? They contain multi-omics integration layer. We will discuss it in the next slide, so I am not elaborating it now. Now, how do we integrate this data? So that is the next thing. We integrate this data with the help of network medicine tools and techniques of network medicine. Basically, we look at, don't see these data points as in isolation. Instead, we see these data points, how these data points interact. See, that is basically what we are looking at is an interactome. You see, we do this by identifying neighborhoods in the network which are either upregulated or downregulated, and see, you can imagine this as a rail network, and the hub genes are the grand central stations of the heart, and if they fail, the whole system collapses. So basically, from our perspective, these are our primary direct targets, those hub genes. Now, how do we translate this into the bedside? Phenomapping. Using unsupervised machine learning, we can group patients based on thousands of variables. For instance, ECG patterns, biomarkers, results of imaging, rather than just simple diagnostic tools like age or blood pressure, etc. And with this, what do? We do a kind of a predictive analytics. Using the machine learning tools, we predict the acute decompensation. We predict the eventuality, basically, before they actually happen using this clinical data. So that is our aim. Okay, now what do we have? What kind of data do we have? What we have is omics data. Omics data, actually, they provide insights into the plasmal and myocardial molecular profiles in heart failure patients. The recent advances in this area is single cell and spatial technologies. This spatial technology, actually, they will reshape our understanding of cell heterogeneity and function, as well as the tissue architecture along with it. So basically, this clinical data analysis focuses on heart failure phenotyping and kind of prognostic modeling. So what is this multi-omics integration layer? To understand the network, we must integrate the data across different biological scales. So this is quite huge actually. This is where the term big in this big data truly resides. The kind of data that which we have is one, for instance, genomics and epigenomics data. Basically, they identify the locus of susceptibility. Second is transcriptomics data. We will be discussing this in the following slides of this presentation. Basically, we are mapping the RNA signatures of myocardial stress. And the third one is proteomics and metabolomics data. Tracking, basically they track the real-time metabolic fuel shift in the failing heart. Now, what are the challenges that which we have in analyzing these data? We call it as 3 V's. Like one is volume, the second is variety, and third is veracity. Because the volume of this data is a big challenge. They run into petabytes of imaging and genomic data. You know, the data in your computer or in your phone is in the range of GBs, gigabytes. So 1000 GB is 1 terabyte, and 1 million GB is 1 petabyte. So now you can imagine the scale of data. Second is a variety. We get, harmonizing data from different hospitals and different electronic health records is a challenge. We have to necessarily, bring them to the same platform. And third one is the veracity of this data. We have to ensure that the noise in this data is minimal so that it won't lead to false correlations. Well, in network medicine, the RNA sequencing technique, we call it as our molecular microscope. So by measuring the transcriptome, what do we see? We can see how the heart is attempting to compensate for stress. Now, RNA sequencing generally can be divided into 2 general categories. One is called the smoothie approach, and the second is called the fruit salad approach. So in the smoothie approach, for instance, we take biopsy of the heart tissue, grind it up, and then sequence it. This gives us a high-level overview of the gene expression changes in a failing heart compared to the healthy one. So in differential gene expression, what do? We identify the genes that are turned up or turned down. For instance, in the first case, something that causes fibrosis, or in the second one, something that is responsible for energy production. And then we do a pathway analysis. We group these genes to see if the heart is struggling with oxidative stress, inflammation, or some kind of metabolic shifts. And the second approach is, we call it as a fruit salad approach, which is called single cell RNA sequencing. So here, instead of a smoothie, we look at each cell individually. So this is the current gold standard in big data research. So you see what we do here is that the heart, or we identify heart not just as a muscle. You see, so instead we identify it as a city of fibroblast, immune cells, and endothelial cells. So our clinicians can tell me better. We can see that the heart, in a heart failure, it might be the fibroblast becoming hyperactive and not just the muscle cells are weakening, you see. So this is the broader context. And in a fruit salad, we can pick up individual cells, individual fruits separately. So it's kind of a parody of that one. And the third one, which is probably the more recent one, is spatial transcriptomics. This is actually the map. We are getting a kind of a map of this RNA. And in this one, generally the RNA sequencing used to lose the address of the cells. And the spatial transcriptomics actually address this particular shortcoming. It allows us to see where the genes are being expressed in the physical structure of the heart. And now, having addressed the first part of this discussion centered on the theme, we'll start this big data investigation. I will present one of our research work. And actually the Title like this. My talk is whether we can study this title of this or is there anything to investigate integrated from machine data that is available transcriptomics for heart or not. Okay, and this is a network. For this we need to have a training set basically intended to find signatures, cell states, so the data acquisition and upstream regulators in a training set is the RNA sequencing involved in this one. Because in machine learning, typical machine learning, having addressed the first part of this discussion, create.
Vinay, there's a problem in
Yeah,
the
there's
Yes,
with
sir.
the recording.
The overlapping voices.
Yeah.
Yeah, Professor Harikrishnan, I have sent a corrected video in the following mail yesterday. So unfortunately, the video that was played was the first one. So that's why.
Okay. Vinay, can you play the other one? You have that?
No, sir, I don't have it on. I'll just.
Okay. Do you have the Dr. Vipin? Do you have the slides with you? You can go live and.
You're muted. Vipin, you're muted.
Professor, that problem may be in that particular slide, and it can, if you can just move on a little bit more, then that can be solved also.
Okay. Can go on with the presentation. Skip that slide. Next.
Data acquisition, integration of them are after batch correction.
Next,
The uniform. Having addressed the first part of again, actually the title of we can see the big plotting it. We are on the now we move from single gene patterns one of our pathway level.
No, sir, I think it's there in all the slides.
Maybe you can show the slides with mute, and Doctor, you can give your comments on that. I think that may be the simplest answer. What do you say, Vipin? If they show the slides, you can give your comments
You
on
are
that.
muted, Dr. Vipin.
Vipin, unmute yourself. Yeah.
Okay, all right. Yeah. So, well, I'll make an attempt.
So
So actually, this particular.
I got the mail now.
Yeah. So please play. Please play the second one. Actually, it was mailed yesterday. It was confirmed by Abhisha that that was the one that was received. So that's right. Sorry. Blood failure and tissue. Right. So for that, we have taken another data set consisting of about 366 samples. And this data set is our validation set. From the expression patterns of 15 genes, we now try to categorize the samples in the validation dataset. Now, from the model we have constructed, we wanted to know whether we can actually differentiate heart failure and tissue samples. So that is our objective of investigation from the normal ones, heart failure tissue samples from the normal ones. The result you can see on the right hand side. The right hand side diagram, if you see it very carefully, it has 4 quadrants. The x-axis has our predictions categorized as normal and heart failure ones, and the y-axis has the actual disease status. And now out of the 366 samples, 166 are normal ones and 200 are heart failure samples. Okay. Now what we could achieve in this case is that about 91.8%, roughly about 92% of our predictions are correct. And in fact, we could predict 198 out of 200 heart failure samples accurately. So that turns out to be about 99%, which is very interesting. At the beginning of this investigation, even we were not expecting it to be of this good, rather. Well, now you must have now understood that our signature is actually built on heart tissues. So the clinicians may ask a very fundamental question: how do we use this information? So because heart tissue of a patient is not easily accessible, so we need to explore the possibility of imputing this heart failure signature, the signature that which we have, we could make. so we should explore the possibility of imputing the signature we have validated from heart tissues onto the blood samples, you see, so that the diagnosis becomes easy. So from publicly available database, we could identify about this paired blood and heart tissue samples, a total of about 422 samples. And our objective was to find out the smallest number of blood genes that can describe the 15 identified genes in the heart tissue. Now, what we could achieve is that out of about 12,000 genes, we could prune down to 960 unique genes that can describe 14 out of 15 genes. Now have a look at this set of graphs. These graphs actually describe the expression of our 15 genes, our identified 15 genes across 3 datasets. 3 datasets we have considered, and these 3 datasets means one is a training dataset, second one is a validation dataset, and the third one is the blood imputing dataset, kind of the blood imputing dataset. And within the first 2 datasets, we have normal and heart failure tissues. We could separate them and plot, and we have separated them and we have plotted them. And in the third dataset, we are trying to impute the heart genes from blood. I mean the expression levels of proteins in the blood, rather. Okay, so we have plotted the heart genes and imputed blood genes side by side, so that we can verify whether we have a case here. Okay. Now across the genes, we can see that the expression levels agree with their disease states within the first 2 datasets. That means 1, 2, 3, and 4 in each of these plots. Their medians are roughly the same. Have a look at the figure. In our assumption, and if our assumption and analysis methods are correct, then we should have the 1 and 3 levels should be comparable, and the 2 and 4 levels also should be comparable. Okay, so from the graph, you can see that they are indeed comparable. Their medians are roughly on the same line of the y-axis. Now from the third dataset, from the third pair, we have predicted the heart gene expression from blood. Okay, so that is what you see in the 5th and 6th box plots. What we can see is that they are in agreement. Their medians are also of the same or roughly along the same y-axis. So the medians are very well aligned. That's what I mean. To cut this long story short, what it actually tells you is the following. Our model is quite capable of predicting the expression levels of genes in heart tissues from blood samples. And I repeat, our model is capable of predicting the expression levels of genes in heart tissues from the blood samples. Okay, this is the workflow for network propagation. This is actually a systemic evaluation. Well, what we have is a list of markers that can describe heart failure, right? Now, in the network propagation, what do? We try to map the crosstalk of these genes. Now, what we can try to understand is that how the cumulative effect of these genes are actually getting translated to a phenotype. So that is the purpose of this particular investigation. It's fairly long story actually, so it's difficult to encapsulate it in the time frame given to me. So I'm not elaborating it further. To get you an idea, you can see a representative illustration here. Okay, I'm concluding here. You must have already made an assumption of what we could achieve. The best papers I read, it always finish with a self-criticism. So we are also following the trend. Currently, the blood-based amputation is not built on with paired samples of heart failure. That is one shortcoming. And second one is this model assumes a monolithic model of heart failure and not considering the etiological, chronological, and comorbidity aspects. So if any of the clinicians are listening and if you can give us the data, then we can solve these two problems. And the third one is if we have more samples, our statistical model will always improve. This is our laboratory at IIT Guwahati, Molecular Informatics and Design Laboratory. May Redkar is the student who have done most of this work. Thank you so much for having me here, and we will see you in another conference in future. Thank you so much.
Thank you, Dr. Ramakrishnan, for that excellent presentation. Any comments?
Can I?
Yes, Dr. Soman.
Yeah. Thank you, sir, and thank you, Dr. Ramakrishnan, and for the excellent presentation and excellent work. Last week I visited you. I was there at IIT Guwahati with another program, and I was wondering, like, now that you are open to explore more. Actually, if you bring in data on patient details and
Yes.
environmental parameters also, then probably just with the blood sample, you will be able to, even without blood sample also, you'll be able to come up with good predictions for heart failure or the grades of heart failure and all, actually using these methods. Like the data on environmental parameters, and these are all linked with the heart failure, and the patient characteristics and their whereabouts, and from where the spatial transcriptome and in the GAS based analysis also can be done. That kind of data is available with, I presume that they're available with the heart failure registry, and a part of that registry data can be explored to come up with novel suggestions. Thank you for the excellent work.
Yeah, Professor, actually we have done this analysis from the openly available dataset. So whatever that is available, we do not get too much of details, like, and even with that openly available dataset, we have to curate it and prune down to reliable dataset in order to make a meaningful analysis. So because of that limitation, because we do not have that data, like, so for example, if we can get data from heart failure registry, for instance, from Chitra, then we can of course do a better work. Yeah, that will solve the first two shortcomings. I have admitted that these are the two shortcomings of the work. Then probably we can solve that thing. Yes.
Yeah, to get the genomic and this transcriptomics data in a large scale will always be difficult. So clinical data you will get in, for example, we have around 25,000 individual patient data from all the Indian registries. But this has only the clinical data. There is no genomics or transcriptomics data in that. So that is
Professor, yeah, Professor, we have collaboration with people who can give us RNA-seq data. So that is part of our work. So we only need clinical data. Yeah.
Yeah, we can.
We can do sequencing.
Already we have discussions, so I think we will discuss it further and take it forward. Any other?
I think we have to move on in the interest of time.
Yes.
Is the next one Dr. Cleland's talk recorded?
Yeah.
Okay.
Hello, I'm John Cleland, Professor of Cardiology at the University of Glasgow, and I'm here to give you a few words about telemonitoring for heart failure, what it should and can offer. We only have 12 minutes, so this can't be comprehensive by any means. These are my declarations of interest. So what must telemedicine achieve? Well, I think one view is that compared to conventional management, it should either reduce hospitalizations and mortality, or if it can't do that, at least it should reduce costs. But there is an alternative view that if it just delivers the same results as conventional care in terms of hospitalizations and mortality, but improves the overall quality of care, not from a physician's perspective, but from the patient's perspective, and it's affordable, then this is a treatment we should really consider adopting. Now, one of the major barriers to the use of remote monitoring is skepticism, and in particular, at least until recently, skepticism on the part of the health professional. And you can see in black that if both the patient and the physician or nurse is skeptical, then they're not going to make remote monitoring work. Whereas if you have people who are open-minded and positive, they're much more likely to get things to work. So this is one of the major barriers to uptake. There have been several developments which have really broken down the skepticism. First of all, there's the issue of pandemic resilience, in particular with COVID. And certainly in the UK, during COVID, the great majority of medical care was delivered remotely, mainly by smartphones. Certainly delivered remotely rather than in person. And for those who are interested in heart failure, we keep focusing on heart failure as a cause of hospitalization. But if we actually look at many large databases, infection, in particular respiratory infection, is a more common cause of hospitalization than heart failure in these patients. So thinking about not having patients sitting in waiting rooms, traveling on public transport where they're exposed to the risk of infection, there could be big benefits from remote patient care. And of course, made much easier by the advent of the smartphones. And you can see this is a sign on the right-hand side, bottom right-hand corner, which is just asking patients not to come and see their doctor, but rather to seek remote care. And this is on the London Underground. So, it really is a big public health message at the moment, which is a lot of patient care can be done more efficiently, more effectively, remotely, rather than in person. Now, one of the bad things about many of the remote monitoring studies is that they did monitor people and they showed you all the monitoring results, but they actually didn't do very much. And you may remember a big study of pulmonary artery pressure monitoring called GUIDE-HF. They didn't really achieve much of a difference with this $10,000 technology. But when you actually look at the data, they really didn't do anything with the information, because the difference in pulmonary artery pressure, which is what they were trying to reduce, was on average only 1 millimeter of mercury difference on a daily basis. So, if you don't intervene, bad things are going to happen. Monitoring doesn't save lives, but the things that you do because of monitoring can. Now, this is from a publication during the COVID pandemic, just thinking about what actionable measurements you need to manage a patient with heart failure. We obviously need symptoms and things like weight, heart rate and heart rhythm can be important. Quite like to know QRS, but you don't have to have that on a daily basis. We'd quite like blood pressure. And all of these things can easily be delivered by remote monitoring with the technologies we have today. We're developing new technologies which can measure congestion and hopefully in the future, point of care devices that people can use at home to measure their kidney function, potassium and natriuretic peptides. And down the left-hand side, you have a range of heart failure interventions you might want to consider. And just think about what measurements you need to make actionable the intervention. So we have lots of devices or monitoring device function, like pacemakers, loop recorders, defibrillators. I think we've already got well established that this is certainly now becoming routine in the UK, USA, and most of Europe, that most device follow-up will be done remotely. The patient doesn't have to come to hospital. for that, and that's now quite well established. For monitoring physiological function, I think there is a little bit more education and debate that has to be done to really engage us in this way. And of course, the smartphone technology is often going to be at the basis of that. This is what I call the telehealth ecosystem, and at the beating heart of the ecosystem is an electronic health record. The electronic health record gives us so many advantages. It means that the information is collected in a way that you can find it, as opposed to hospital notes, where you can often spend hours looking for some information that simply doesn't exist, but you don't know it doesn't exist, so you keep on looking. And that can waste a huge amount of time. You have the patient. Often the patients are elderly, but they can be supported by informal carers and family, who can often be quite tech savvy. Pharmacists, family physicians, heart failure nurses, heart failure specialists, if they can all see the same record, and of course the electronic health record can triage a patient's problems and identify the person most appropriate to deal with the problem. So, if you're missing a prescription, maybe you want to see the pharmacist. If you've got a bad cough, then maybe you want to see the family physician. If your ankles are swelling and your knees are edematous, maybe you want to see the heart failure nurse or specialist. So the electronic health record, I can't say how important it is. It's what supports decision support. And that's, I think, importantly, we should give that decision support into the hands of patients and carers, but also healthcare professionals. It's important, if we're going to have personalised remote care, that health professionals are only for occasional oversight. They shouldn't be involved in a daily look at the patient's records. That can be so easily done by the electronic health record, which can produce alerts. It can say everything is fine, you don't need to look at this patient. This patient now flashes up red. You need to look at this patient, there's something going wrong. You need to make contact with them. You need a good communication system, but smartphones, I think, have largely resolved that. And what you want is actionable information, followed by action. So, and to put this in a different context, we can think of it as a cycle. We've got the electronic health record that can produce the educational modules that the patient needs, because if the patient knows what's supposed to happen, they can be a major help. You do need an accountable healthcare professional, so that somebody is responsible. If everybody is responsible, then nobody's responsible. There has to be somebody who the buck stops here with the remote monitoring. Should be integrated with existing health services. Then you've got loads of user-friendly sensors that we'll come on to in a moment. We need to decide on what the therapeutic goals are. Use this as audit to see how well the care is, then feeding back to the electronic health record. You may be wondering what this piece of winding road on the left-hand side of the screen. That's all the early trials of telemonitoring were all about trying to spot somebody about to be hospitalized and doing something about it. It's not very good. What you want to do, like that archery target, is get the patient into the blue, the ideal range. Gold is an action range. You should be acting. And by the time it gets to red, you're getting very late in the day for intervention. And if you get the patient into the ideal range, you're much more likely to improve the prognosis, prevent adverse ventricular remodeling, etc., etc. What about sensors? You have active and passive sensors. The active sensors mean that the patient has to do something to give you the information. There's passive sensors. These are ones that can just be placed in a room in the patient's home, and it will collect the information. It doesn't require the patient to do anything at all. And we have all sorts of technologies, everything from symptoms, voice diagnostics. You can tell my voice is perhaps not, well, if you've heard it before, you'll know that it's not my strongest voice. You have weight. A bioimpedance can tell us about body fluid, blood pressures, oxygen saturations, all sorts of things. So it should be time efficient. Dentist tells you to spend 2 minutes twice a day brushing your teeth. Cardiovascular health check takes much less time than that. One of the things that I think we should be wary about is video consultation. This is time consuming, and it's probably not the most effective or efficient way that telemonitoring can support patient self-management. But of course, it is one of the things in the armamentarium that you should have. And it's quite interesting now in the UK, if your GP refers you to a specialist, that you can choose that you want the quickest appointment, in which case you'll get a video consultation from somewhere in the country, which is perhaps 300 or 400 miles away. And he will then organize what tests you need, and they can be organized locally. But you can see how really the landscape of telemonitoring is changing. I think there's a green agenda developing in medicine, and telemonitoring is green. It's less travel, less air pollution, reduced use of fossil fuels, fewer car parks at hospitals, fewer hospital buildings, and much more convenient for patients. So what is the evidence? This meta-analysis is a little bit out of date, but I think it's still relevant. This is the effect of telemonitoring on all-cause mortality. The hazard ratio is 0.80, so a 20% reduction in mortality, and that's highly significant. It doesn't include two major trials that I think should have been included in this analysis, one of which showed a odds ratio of 0.54 for mortality, so that's almost a 50% reduction, and the TIM-HF study, which showed a 30% reduction. So how does this compare with other treatments that you might consider are standard of care for patients with heart failure? And I guess one of the new kids on the block are SGLT2 inhibitors, and you can see that they only deliver a 13% reduction in mortality. So you get about twice the benefit from telemonitoring as you get from an SGLT2 inhibitor. And I think the same story is true for hospitalizations for heart failure. You can see they're very similar for SGLT2 inhibitors and for telemonitoring. And if you're going for HFpEF and the telemonitoring studies, even for the HFpEF studies, not so great. There are other benefits. It's convenient for patients. It's a respect for patients' time. The electronic health record can develop decision support tools and is going to support machine learning and artificial intelligence as they are introduced as part of the armamentarium of healthcare. There's social distancing, so we can avoid the common cold, flu, COVID-19, and whatever is going to come next. I think it's resilient, so when you have the next pandemic, you can still more effectively deliver care at home. I think you can engage family and informal carers with the patient's care. You can prescribe not only medicines or other interventions, but also educational videos. So, and we've done this for many years, and it's interesting how the patient will often watch it, then they'll often ask to watch it again with their family or carers. And so they'll often watch it 2 or 3 times to really understand and reinforce the messages, which of course we don't really have time for in our healthcare system. I don't know about India. For patients who have been hospitalized, you can get early discharge, leading to continuity of care. because many of us like to keep our patients in hospital till we're sure they're stable. But if you can discharge them into a remote monitoring environment, then you're much less strict on that. And then in terms of your health record, you can make sure that treatment's been implemented and it's well audited. Home telemonitoring is never going to work for every patient, but if it works for some, a sizable proportion, then the resources can be targeted more effectively for other patients who can't or won't engage with telemonitoring. So finally, telemonitoring doesn't need to improve outcomes to be better than standard care. If telemonitoring is not significantly worse than standard care and it's affordable, then for all the other benefits it brings, it should be adopted. Thank you very much.
Okay. I think that was a nice overview of telemonitoring as it stands today. I guess Dr. Cleland is not around, but any comments or questions? Comments? Anybody? I think COVID taught us a lot about teleconsultations and telemonitoring. And teleconsultations are still a reality in our country, although Dr. Cleland mentioned that it is not as good. But till such time that these technologies evolve more, things like voice recognition or voice assessment for heart failure comes in, many of these techniques would continue to be used.
Especially in heart failure where the continuity of care is important. Telemonitoring and telefollow itself can improve the outcomes of the patients.
Right.
Biju, you are telling something?
Yes, I also want to echo that in India, actually, we are having the medicine program. It's called e-Sanjeevani. Actually, we have e-Sanjeevani, which is patient to doctor or patient to health worker, and there is a doctor to doctor e-Sanjeevani also. And when we have divided that in two lines, actually, doctor to doctor is a doctor, basic doctor trying to contact a specialist, and we found that is quite effective. And I've seen that even in northeast districts, actually, the community health workers are using this e-Sanjeevani platform to continue to treat hypertension, diabetes, etc. and all. So, of course, connectivity is a problem, and we have to work on having good EHR or EMR in Indian scenario. But this is a possibility in India also. Thank you.
Thank you. Dr. Stevenson?
Yeah.
Yes, can you hear me?
Yes, yes.
Yeah, we can.
Excellent. Excellent. I think Dr. Cleland, as always, is really very helpful and gives us a great perspective. I think one of the things that's key for us to make any kind of remote monitoring useful is that we want to know for the individual patient, what is their ideal profile? How can we measure it? And then if they're not there, what therapies are we going to use to get them there? At the moment, I think, much as in the first talk, we make a mistake by assuming that we want to take an average goal and give it to all the patients. But I think one of the challenges is to individualize the physiologic goals for each patient, whatever they may be, by voice or by invasive measurements or by multi-sensor integrated numbers, and then figure out how we use our therapies to get them into this ideal range. I think John Cleland's exactly right about find the ideal range and try to keep it rather than just waiting until a patient gets close to falling over the cliff.
But Dr. Stevenson, I think the technologies have to be much simpler. Implantable technologies are not going to work in population. They are okay for certain high-risk individuals, but otherwise it's got to be something much simpler. Some of our colleagues are developing now a transdermal NT-proBNP measurement. They have already developed the troponin, and that was presented in, I think, ACC or somewhere. So
yeah, they got the best innovation award also.
Best innovation award. So now the same group is developing transcutaneous NT-proBNP. So, simple technologies like this, educating the patients to check their weight, to check their blood pressure, and to check their pulse rate. These 3 or 4 things, if they are monitored remotely by a nurse or something, that itself can at least tell us whether the progress is all right or not.
I think there's no doubt about it that many people can be managed with the non-invasive techniques, but the challenge is to figure out, we need to understand physiology in general better about,
Absolutely.
for instance, what BNP, I mean, some people run a BNP of 400 all the time, other people run a BNP of 1400 who are sicker, and trying to figure out for each patient, what is the range? And I think we, at this point, don't yet understand all the physiology well enough to be able to reliably do that for everybody. So, one of the advantages I see of the invasive monitoring is that we've just learned so much about the sequence of things, what makes a difference. And I think once we know more about that, it will be much easier to generalize it into a non-invasive measurement. It's kind of the same idea as our first talk, in that you come up with the really complicated physiology like they get from the transcriptomics, but then you have to figure out how to relate it to something that's easily accessible, like what you can find in the blood. And this would be kind of an analogy to that. What really happens in the physiology of heart failure decompensation, and then figure out what easy measures will parallel that.
Right. Shall we go on to the next talk, Dr. Hari?
Yeah, please.
Is Dr. Roy's talk
It's
also
recorded.
recorded?
It's
Yes.
recorded.
Is Ambuj here?
Ambuj is not, he has some other meeting,
Okay.
so he has recorded.
Okay, let's proceed then.
Good evening, everybody. First of all, apologies for not being live on this program due to my travel schedule, and also my great gratitude to the organizers, especially Professor Hari Krishnan, for giving me opportunity to speak at this important meeting. So I will be speaking about digital care models for heart failure and its precursors also in low resource setting, and its importance in improving patient care. So unfortunately, we have the label of being the cardiometabolic disease capital of the world. And because of the enormous burden of hypertension, dysglycemia, and CAD. As you can see in this nationally representative sample from all over India, that the burden of these risk factors, which are precursors to heart failure, are extremely high. So we have over 200 million people living with bad glucose or dysglycemia. We have over 300 million people with hypertension, and similarly very large number of people with obesity, which are, as I said, all precursors for heart failure. Unfortunately, not only is the burden high, but the level of care for these diseases is very suboptimal. As you can see from one of the examples here, which I've cited, is for heart hypertension, which is one of the most easy things to treat in terms of drugs and availability. But if you can see in India, only 1 in 12 people really have their blood pressure under control. And this leads to future cardiovascular disease in various forms, including heart failure. If you look at secondary prevention, which is giving therapies for people who already have heart disease, and so that they don't have recurrent problems of related to cardiovascular disease, like somebody who's had an MI needs to be on certain drugs so that he doesn't have another MI and doesn't progress to heart failure. But again, and these people are of the highest risk, but even in these group of people, in this large study done under the PURE study, the cohort from India and other low-income countries, only 20% at baseline and 25%, about 1/4, at the end of the study were receiving the much needed secondary prevention drugs. Looking at how do our patients with heart failure do, and this is a lesson from the GCHF, the Global CHF Conductive Heart Failure Study, which studied over 40 countries in different regions of the world, including from several centers, which we recruited over 2,000 patients from India. What we saw that the mortality, LMICs, which you see are the patients who are included from India. So if you see the low income countries and the low middle income countries had more than 2 times mortality to that of patients who were from high income countries. And even after adjusting for risk factors, there was 60% higher risk of people dying from heart failure once they had if they lived in low and low middle income countries. One of the reasons could be we have very low hospitalization rates. So this chart, if you see carefully, shows the blue is the hospitalization rate and the red is the mortality rate due to heart failure. So if you see in the high income countries, the blue bar is very tall and the ratio of hospitalization to death is 3.8, while if you see low income countries, it's only 0.6. That means the mortality or the events happening once you have been diagnosed with heart failure are more often death in low income countries than hospitalization, which in real terms really means that we need to manage our patients very well, because once they are in trouble, the access to healthcare, to hospitals is very poor. And unfortunately, most of these events leads to mortality. And why is that so? It's because the use of GDMT or guideline directed medical therapy or optimal medical therapy received by these patients in the low income countries and low middle income countries are much lower than what should be. So if you see the high income countries, the bars for beta blockers, RAS inhibitors, and the beta blockers is much higher than in other parts of the world. So basically means we do not give the guideline directed medical therapy as needed. Even from our experience, this is an unpublished ad, but part of a study where we had patients from India in this inter-CHF study, which was of study of congestive heart failure patients in low middle income countries. If you see, only 56% of the patients were prescribed beta blockers and 60% were prescribed ACE inhibitors, ARBs, and MRA, which is mineral corticoid receptor antagonists, were only 50%. And if you see, only very few of the patients, 1/3 of the patients for beta blocker ACE inhibitors and just 4% of patients for MRA reached even the half dose of prescribed medicines. So it only means that even if we're prescribing these medicines, we are prescribing them in suboptimal dose. And these all three medicines are called the pillars of heart failure management, and they are essential drugs because they prevent mortality, they improve survival in heart failure patients. So, and this subsequently leads to much higher mortality. And within low middle income countries also, India fared worse than countries in South America or China or Southeast Asia. We were just much better than Africa, but still our mortality rates were almost 21% at the end of 1 year, which can be substantially improved if we improve the guideline directed medical therapy for all our heart failure patients. So obviously we've not been doing a good job, whether it being management of precursors of heart failure like diabetes, hypertension, or it be management of heart failure per se. So we have to really think of newer strategies like use of digital health, which provides scale and through task sharing, which I'll share what that really means, I'll share with you in the subsequent slide. But that really means you can use non-health physician health workers and help to scale up management of these, given the large burden of patients that we have with these risk factors, and it is probably impossible for the physicians to reach everybody. We can improve guideline directed medical therapy through what is called the CDSS or clinical decision support systems, which are algorithms to better manage patients by providing evidence-based therapies. And it also helps in reducing physician inertia because it gives prompts to up-titrate medicines. And in very, very busy clinics that most of us run in India, it is not unusual to just continue similar treatment and look at the next more sicker patients. But this is the opportunity, as I said, to improve the therapy further and reduce the physician inertia, which can be helped by CDSS. It helps provide an electronic health record. And more importantly, the digital health can help in long-term follow-up, which is very critical because these are lifetime diseases and they require long-term follow-up. And digital health can be a very big support in that. So I'll just share with you some of the work that we've done in terms of using digital health. We have an app which is called the Empower, and which we've successfully employed in several peripheral health centers, and which really what it does is when the patient walks in, a nurse or a care coordinator really assesses the patient. He works like an intern, does all the workup of the patient, puts in the basic therapies that the patient is taking, measures the blood pressure, glucose, takes a basic history. And based on the blood pressure and diabetes status, this prescription is generated for the patient, and then they take it to the medical officer who accepts or makes changes to the prescription, and then nurse care coordinator enters that into the app and gives certain basic counseling for these lifestyle diseases, and patient walks out with the prescription. So that's how the flow of this Empower mHealth system works. It works on tablets, desktops, and as I said, it can help with screening and registration of patients. It documents their demographic history, anthropometry, and basic lab investigation, and then using the CDSS, it generates a individualized prescription, and there are almost 2,500 clinical management scenarios in the Empower CDSS, and it provides an individualized management plan for hypertension, diabetes, dyslipidemia, tobacco cessation, lifestyle, and CVD, secondary prevention prescription. And it, in the follow-up, sends reminders to the patients as needed to come back for follow-up. So it does send SMSs and reminders, and it stores patient data in electronic format, which is critical for these patients with chronic therapy. We've had several experiences and publications based on our Empower experience, where we managed conditions like diabetes, hypertension, and we kept adding things to that, including secondary prevention and COPD. And Empower Heart project was a pilot study which began in Solan, and then we did a trial in 40 CHCs of Haryana and Karnataka under the mWellCare trial, which is published in Circulation. Then we scaled up to include one entire district of Punjab under the ITREC study. And then our team also worked with all 40 CHCs and district hospitals in Tripura, where we again provided care through this. And it clearly showed that putting this was feasible. It improved screening, it improved people who are on therapy, and led to significant reductions in blood pressure and diabetes in the subset of patients. But today I'll not go into details of that, but rather discuss one study which we have just completed. It's yet to be published. So please do not share the data, but this was part of our Emerging Global Leader Award that one of our former PhD students, Dr. Kavita Singh, got. It's called the CQUIP study, of the Collaborative Qualitative Improvement Initiative for Cardiovascular Disease Care in India. It's already designed, its rational design and baseline characteristics have been published in earlier, which people who are interested can go through it. But basically, the study intervention is an electronic health record system, on top of which we've added clinical decision support system now, not only for diabetes, hypertension, but for CAD, for heart failure patients. And the other element was, an important element of this trial was having non-physician health worker who was trained and under supervision of the PI, provided that bridge, which is very important in these patients, between the doctor, and served as a bridge between the doctor and the patient. He gave more time, came up with patients were far more receptive to talking to these people than doctors, and they gave much more time. So and then it send text message based reminders for lifestyle changes and follow-up visits, and there was an audit and feedback reports to the provider. I will, in view of dearth of time, not go into the details, but it was a randomized trial with the usual care and where the CQUIP intervention was done, and there was a 12-month end of study follow-up. These are some of the medicine reminders, diet and weight management texts that were sent out. These messages were personalized and told the patients of when to come for follow-up. And as you can see, themes were from diet, exercise, where relevant, tobacco, alcohol, cessation advice, medicine reminders, clinic visit reminders, weight control reminders, blood pressure, and blood glucose monitoring reminders. And then it was given at a predefined frequency, and it was provided, it really was a link for the patients to acknowledge that they have read the message. There were 4 study sites, 3 in Delhi and 1 in Karnataka. and each recruited about 100 patients. The primary outcome was, it's a pilot study to look at this intervention. The primary outcome was to look at the feasibility of implementation, the fidelity of the study protocol, and its adoption and acceptability among both the patients and the physicians in terms of the intervention that was given. And there were, of course, processes of care measures, which I'll come to as secondary outcomes, and exploratory outcomes. Because it's a small study, a 400 patient study, the clinical changes were just an exploratory outcome. This was the baseline characteristics. The usual chronic patient, about 57 years was the average age. 70% of patients about those with coronary artery disease. Only about 1/5 were those with on heart failure, and 40% were hypertensive, another 40% odd were diabetics. So what we clearly showed, if you can see this diagram, the fidelity of the CQIP strategy was very high. Even if you look at the middle figure, the adoption of DSS prompts was largely very well accepted in the range of 70 to 80%, except for hypertension, which was about 50%, because of various factors where the patient doctors overrode the DSS because they felt maybe this was white coat hypertension and then didn't want to escalate the therapy further. And there was very high acceptability of the CQ strategy at the end of study by patients and the PIs and the clinicians who were part of the study, as you can see in the rightmost diagram. What it did, as you can see in this figure, is that among CHD patients, there was significant improvement in the use of antiplatelet drugs, in the use of lipid lowering, which was 14% higher. In the intervention arm, the ACE inhibitor was not very significant, but beta blocker use was 17% higher. And the use of the combination of the guideline-directed medical therapy, which was antiplatelet plus statin plus inhibitors for beta blockers, were 45% higher in the intervention as compared to the usual care. So significant improvements in guideline-directed medical therapy. The number of heart failure patients was small, but if you say, and the changes were not very significant, but clearly there was a trend to better use of guideline-directed medical therapy, like 26% higher use of ACE inhibitors, RAS inhibitors, beta blockers, or mRNAs in the intervention. So the thing was, because of a small number of sites, this benefit did not come out very well, but in the CHD it was clearly better. When looking at the adherence to prescribed therapies, it was clearly seen that the CQIP strategies led to better prescription, adherence to prescribed treatment, better adherence to diet plans, and better adherence to physical activity. These are all, these are lifestyle diseases, and lifestyle changes are a very critical part of management of these conditions, and they clearly did better when we use the CQIP strategy. When we look at the processes of care, the clinical visits were better in the intervention arm. The BP checked more frequently because you have a nice system of flow or protocol to do that. You had a cholesterol testing, blood sugar testing, physical health score management, the treatment satisfaction score, the satisfaction with current treatment, the overall satisfaction were much higher in the CQIP as compared to the usual care arm. These are important endpoints for a pilot study, and they were clearly better in the intervention arm. So I would like to say that, heart failure and risk factor burden, as you have seen, is very high in India. Unfortunately, management of these risk factors for heart failure and even heart failure in terms of usage of guideline-directed medical therapy remains suboptimal. So we need to think differently, we need to think innovatively, and I think digital health or mHealth is an important bridge. It can't supplant physicians, right? But it can be an excellent supplement or aid, I would say, along with the use of task sharing with non-physician health workers to improve the processes of care, to improve guideline-directed medical therapy, and to ultimately improve outcomes in management of these sick patients, whether they have the risk factors or they have the disease. And the CQIP trial clearly showed the feasibility of implementing it for CAD and heart failure patients. We need wider testing of this technology so that this can be really taken forward in a larger way. So thank you for your attention. And I would just end with this quote by the philosopher Herbert Spencer, that the great aim of education is not knowledge but action. We have the knowledge, we have the tools of management of these chronic diseases, but we need to do that better. We need to translate that knowledge into action. Thank you.
Okay, I think that was a very nice talk and great to see the application of this technology, very complementary to what Dr. Cleland presented, but in our settings, and does demonstrate good results. These kind of initiatives can be, if they can be spread across the other parts of the country, I'm sure ultimately they'll translate into better outcomes for our patients. Dr. Suman, any comments from you? And would you like to sum up the session? Because we are about 15 minutes behind time.
Yes, yeah, actually, yeah, the last presentation also was very interesting, especially the Empower, where we are bringing in non-physician assistant or the nurses. In India, actually, we can use more of these nurses for this kind of work, and that will ease out the burden on doctors to type in details into the digital EMR or EHR. And digital health is the way to move ahead. Like Government of India is also coming up with a new mission to use artificial intelligence for healthcare. That's it's the background works are all going on. In one of our telemedicine unit also, we use the nurses to enter the details into the EHR. So that's a good move. And overall, all the three presentations were very good. Actually, I was much impressed the way cardiologists are working in this line. And of course, digitalization is coming in, and there were some speculations that with the digitalization, doctors will lose their job. But it seems that digitalization helps doctors to improve their efficiency and increase their access, and quality care can be delivered to our patients, especially in India, where the resource crunch is there. This kind of innovative technologies can be used in a very pragmatic way, in an optional way to increase reach. So that's all. Thank you, sir.
Thank you. Dr. Stevenson, your hand is up. Did you have a comment?
I wanted to say just such incredible congratulations. This is wonderful work and so valid. I think we're not making the right comparison when we say, how does it compare to physicians? Because we don't have them. We don't have anywhere near enough physicians to handle any of this. So I think in many cases, we're comparing it to no care, and it is clearly so much better than that. So many, many congratulations. One quick comment. And you mentioned how many patients don't have access to care before they get hospitalized and are very ill. We're increasingly seeing that problem in the US, that patients are often diagnosed first when they show up in the hospital because they don't have good care outside. And we need to be careful about not jumping too fast to get them on all their pillars of heart failure therapy, because when they're very decompensated, often they don't tolerate those. And so I think what's really important is to get them plugged into a system of care where they can gradually be worked up onto those therapies. Because I see so many people hospitalized here who, in fact, they can't tolerate beta blockers yet because they're too sick. So I think it's important to emphasize the connections so they have the continuity of care, because often it's hard to get all those pillars started in someone who has been very decompensated.
Very right. Thank you for your comments. So, Dr. Harikrishnan, I think we can close this session. We are about 15 minutes over, so let's go on to the next session.
Yeah. So thank you, Chairpersons, Dr. Chopra, Dr. Biju Soman, for the moderating the session and the comments. Now we'll move on to the next session. I invite Dr. Nagesh DS, Dr. Uday Jadhav, and Dr. Ajay Behel to moderate the session and take it forward. Over to the moderators for this session.
Thank you, Dr. Harikrishnan. So first talk is by Dr. Muralidharan CV, and I request him to listen.
before Dr. Murali starts, I should introduce him. Dr. Murali is the main person who is behind the development of the Chitra heart valve, and he is behind all the major device developments in our biomedical technology wing. So over to Dr. Murali.
Thank you, Dr. Hari. Is my presentation visible?
Yes, your presentation is visible, but your camera is not visible.
You are not visible. Your presentation is visible.
Presentation is visible.
Now it's better.
Yeah, coming better. Yeah.
Okay.
Yeah, you can start.
Okay. Okay. Thank you. So the topic suggested by the organizers is challenges and innovations related to indigenous medical device development with focus on cardiovascular devices. In fact, if you look at any medical device development, there are two basic aspects which need to be looked at. One is design related, second one is material related. Most often, there is a tendency for stressing more on the materials, mainly because we have got only very few metals, alloys, or polymer materials, which are what we call as biocompatible. And in this process, the design-related complications takes a backstage, and which leads to maximum number of failure modes in devices, especially in cardiovascular devices. And if you look at the cardiovascular device segment, what we need to understand is the behavior of blood when it comes in contact with foreign materials and foreign devices. If you look at the range of velocities conventionally blood passes through. In large vessels, it is somewhere about 2 meters per second. And in small capillaries, the velocities could be as low as 0.1 millimeter per second. But when we reach a situation beyond these ranges, this 0.1 millimeter per second to 2 meter per second, blood starts misbehaving. And this is the biggest challenge while designing any cardiovascular device. Unfortunately, blood cannot be visualized for its velocity, shear rates, etc. very easily. So we may have to depend on computational techniques like computational fluid dynamics or experimental techniques like laser Doppler anemometry, pulse Doppler anemometry, or particle image velocimetry. These techniques are quite expensive, time consuming to set up, and a trial and error approach in this segment becomes extremely costly. So that is where people are moving towards computational techniques to initially arrive at a reasonably good design and then move towards experimental methods to validate their design. Just to take an example, what happens to blood when the shear rates means the rate at which velocities change close to the device surfaces. When the shear rate becomes extremely high, it induces blood cell damage. When you have an RBC damage, it leads to release of platelets, activation of platelets, which in turn leads to aggregation. In most of the cases, if it is happening close to the device surface, then this platelet activation will lead to either thrombosis of the device or embolism episodes. Now take the case when the velocities are too low, such that the associated shear rates are very low. This again causes what is called platelet adhesion, leads to aggregation, and eventually leading to thrombosis. So the main challenge of any designer is to ensure that the blood flow rates and blood velocities doesn't cross these boundaries. Now, this particular chart shows the blood velocity, the blood shear rate profiles of a typical mechanical heart valve when the flow develops across it. The threshold what we are looking at is somewhere about 20 Newton per meter square. That is a level beyond which there could be a rupture of RBCs leading to platelet activation and other complications. Now, the primary objective of any designer is to ensure that these ranges are never seen in the final device. So the design objective is to break down the peak shear stresses below the hemolysis thresholds. And that is where the computational techniques can be effectively used for studying the shear rates and arriving at minor design changes to ensure that in none of the regions around the device, these shear rates crosses these limits. So if you look at the results in this particular case, you can see that the value, the peak value is about 1800 millinewton per meter square, or somewhere about less than 2 Newton per meter square, which is sufficiently below the threshold levels which can lead to damage. Another aspect related to designing for blood compatibility or blood contact is look at the velocity profiles. Why these velocity profiles are important is because whenever you have straightforward laminar flow, there will be minimal chance for thrombus formation or thromboembolism. Whenever you have disturbances or turbulence around the device, this can lead to formation of thrombus. Now, the question is, if you put a device in the bloodstream, definitely it is going to obstruct the blood flow. There will be turbulences and flow stagnations and low flow regions. So again, here the design challenge is to make the flow velocities as uniform as possible so that mixing or turbulence are minimized. So these two challenges are the most dominant ones as far as designing any cardiovascular device is concerned. Now let's try to look at some of the innovations we could bring into the cardiovascular segment, especially in the case of artificial heart valves. I thought the innovations has to be discussed always with reference to some devices. In fact, there are two models of the tilting disc valve which has come to the clinic from the institute. The first one is the model which is already available in the market for the last 30 plus years, where more than 200,000 implantations has been carried out. The second one is a new generation valve, which has just started the clinical evaluation with over 40 cases completed in the pilot study, and the pivotal study is planned for the next quarter of the year. Now, in the first model, we introduced what is called a soft occluder. The soft occluder is a concept which is not novel in cardiovascular devices, especially in artificial heart valves. There are quite a few devices in the early stages of the valve development. But the main problem in some of these devices was the longevity of these soft occluder valves. So we could come out with a model with the longevity ensured at the same time with the soft occluder. So what are the advantages of this soft occluder? First one is very low potential for cavitation. We'll come to the concept of cavitation in the subsequent slides. Very low impact forces and sound levels. So what is the advantage or the importance of this low impact forces? If you look at the structure of any artificial heart valve, there will be a soft suturing which is used to stitch the valve onto the muscles of the heart. Then there will be the actual functional device with either metallic or a pyrrolic carbon structure. This suturing is a soft material where the tissue ingrows and forms a nice joint. Whereas the metal frame or the pyrrolic carbon structure is a rigid material. So whenever valve closes, there is an impact force, and this impact force creates a small relative motion between the rigid structure and the soft suturing. And this happens every time the valve closes. And this continuously irritates the interface between tissue and the metal, or tissue and pyrrolic carbon. This is the primary reason for pannus formation, tissue overgrowth, and other associated complications. The second major problem in any metallic device is that even though we say that these are having extremely good corrosion resistance, this extremely good is a relative term. Whenever we put a metal in the tissue or in the bloodstream, there will be corrosion. There will be elution of metal ions into the surrounding tissue. And this in turn will generate an inflammatory response into the region of the tissues close to the metallic device. And this inflammation will bring in scavenging cells, giant cells, and make or create a fibrous capsule-like healing response, which is not the best of the healing responses. So if we can have a method by which we can bring down this metal ion elution into the surrounding tissues, that will substantially improve the healing response. That is what we have achieved in the second model, apart from other improvements like MRI compatibility, better flow profiles, etc. We try to incorporate a ceramic coating onto the entire metal device, thereby completely isolating the blood, tissue, and the metal structure. This ceramic device is an impervious device which doesn't allow metallic ions to come into the surrounding tissues, thereby improving the healing response and thereby enhancing the longevity of the device. So we are talking about the cavitation phenomena in mechanical valves. In early days, it was thought that this cavitation phenomena will occur only in valves used in artificial heart or left ventricular assist devices. But later it was found that the same phenomena could occur in natural heart also. This was demonstrated and documented in many research publications. So what is this cavitation phenomena? Whenever any fluid is brought to a pressure level which is below the vapor pressure of the liquid, there is a possibility of formation of vapor bubbles. These vapor bubbles are not the ones which create problem, but when the pressure recovers, these vapor bubbles collapse, creating shock waves and pressure and thermal shock waves in the vicinity and generating fluid microjets, which can damage device surface as well as the blood cells. And the advantage of this soft disc comes from the fact that the soft disc sort of introduces lesser impact forces and lesser negative pressure transients across the valve. Why these negative pressure transients are coming? Now you take the case of a tubular structure like aorta, where you have a mechanical valve and the blood is flowing in one direction. Suddenly the valve closes. When the valve closes, immediately after the closure, there will be a continuous movement of blood volume from the aorta into the into the distal region. This movement of blood volume due to inertia will lead to the formation of negative pressures. And this negative pressure, when exceeds the vapor pressure of the fluid, these bubbles form and create the damage. So what we have found is, this is a study by University of Iowa. Both experimental and animal studies were carried out. But we found that typically in hard disk based valves, the negative pressure transients could be as high as 500 to 600 millimeter of mercury, whereas in soft disk valves, this is very close to 250 or less than 300 millimeter of mercury. So the propensity for formation of cavitation bubbles is extremely low in these devices. Another, of course, advantage is the reduced sound while closing and operating these valves. This has been studied extensively in various experimental and animal trials. What we found is, if you look at this chart shows the sound frequency spectrum of various mechanical valves. And you can see that all the pyrolytic carbon based valves have a higher frequency spectrum compared to the soft disk valves, which is in the bottommost spectrum. And this is sort of obviously would have been noticed by many clinicians during sort of checking the working of these valves. And of course, the titanium nitride closure, I mean, the advantages I've already discussed. So with this, I think I'll close the session and I'll be happy to answer any questions which come up. Thank you.
Thank you so much. That was a very nice, lucid, and such a clear presentation. I just have one or two questions. So the first question would be that what did you aim to achieve when you went for the second generation heart valve? Between the first and second, apart from MRI compatibility, what else were the improvement? And second, what is the data that is available on the MRI compatibility of the first generation Sri Chitra valve?
Sure.
Thank you. Thank you.
Apart from the MRI compatibility, we wanted to improve the minor orifice flow. Basically, the effective minor orifice area available for the first generation valve was about 24% of the total, which we wanted to increase it to 34% of the total, thereby enhancing the minor orifice flow. And most of the Panus formation, what you observed is in the minor orifice. And the second point is having this coating of the ceramic coating on the surface of the metal, thereby reducing the propensity for metal ion elution into the surrounding area, thereby attaining a better healing response. Regarding the MRI compatibility, both these valves are MRI safe, to mean that there won't be any untoward event towards the patient, but there will be artifacts on the signals. Now, the quantum of artifacts on the signals is reduced by almost 80% in the second valve.
Thank you. So just one clarification. Is a 3 Tesla MRI compatible with the first generation Sri Chitra valve?
Yes.
Thank you. Thank you so much.
Any more points? Anybody else?
I think Dr. Stevenson is raising. No. Okay.
So if no more questions, thank you, Lithan, for the excellent presentation based on his 4 decades of experience with the medical devices. Thank you very much. Now I request Dr. Uday Jadhav to continue with the moderator. Dr. Uday?
I think we'll request Dr. Lin for her talk. She has already recorded. I think it will be played and she will be coming live for the discussion.
I'm very happy to be here at this meeting from a distance, but hopefully we'll be close to you. On remote monitoring for heart failure, what have we learned? I've provided unpaid consultation to these companies, and Vanderbilt receives research support from Edwards Life Sciences. So what I'd like to review is some lessons that we've learned through monitoring. Monitoring the mystery out of heart failure rehospitalization, the impacts of PA pressure-guided therapy for heart failure all EF, then some specifics on HFrEF, then about HFpEF, and then we'll eventually move on to just final speculation on a few of our next lessons to learn. Well, the first thing we learned, and this is back a long time ago, from the COMPASS trial back in the mid-2000s, we were really wondering at that time, where do heart failure events come from? All of a sudden, a patient gets sick. And what we learned from hemodynamic monitoring is that, in fact, the pressures increase quite gradually prior to a heart failure event and then come down quite rapidly once the patient is treated. We now have information on this from many other studies, as shown here on the left side. This is several different trials looking at this remarkable physiologic parallel of how these pressure curves look, whether you look at the PA mean, the PAD, right ventricular end diastolic pressure. And if you compare these lines of ascent and descent to the dotted lines are people who are monitored with devices but have not had a heart failure hospitalization, but have had non-heart failure hospitalizations. More recently, we've shown exactly the same trend looking at seated pressures instead of supine pressures using the Cordella device. And in this one, you can see that with spontaneous monitoring, there is no change in the weight, as shown in red, the heart rate in yellow, or the blood pressure in green before these events. The latest hemodynamic monitoring information is from left atrial pressure monitor, and this shows here in a more collapsed slide, looking at the increase in pressures prior to the hospitalization when the pressures are highest, and then they come down rapidly. I'm going to talk now about the impacts of PA pressure-guided therapy, first of all talking about all ejection fraction patients. There's remarkable unanimity in the benefit, which has been demonstrated to decrease heart failure hospitalizations. And these trials, shown on the left, have included all ejection fraction, as do the other ones on the right. Some of our latest information is the Monitor HF trial, which was a non-industry sponsored trial done by the Netherlands, which showed a remarkable increase in quality of life for the patients who were monitored, as shown in the turquoise line, versus those who had standard care, shown in the bottom. This is 12 months. Also, a very interesting study that recently has come out, looking at the post-approval study at a subgroup of patients who in fact had the BIPQ questionnaire, which is the brief illness perception questionnaire where patients answer how much their illness bothered them. And you can see on the right that there is a marked decrease in the perception of illness that occurred within the first half year and remained low out to 24 months, which may explain the remarkable adherence of these patients to monitoring, which by 2 years was still 82% a day, the median number, and 95% at a week. I'm not going to review in depth any of the other devices, but I just want to indicate there's, of course, an expanding landscape of monitors. And in terms of how we select them, we need to think of a number of factors. Number one, how stable is this patient? Do you just want to have surveillance of a stable patient for the exceptions in their case, or in a patient who has known congestive risk? Are you trying to actively manage them? Very different devices that are needed for these. The specificity and kinetics to know the initial change in parameters and how quickly those parameters change after you've made an intervention. And then, are you looking for long-term, over months and years, or are you trying to look at someone who's just in the first 90 days after a decongestion episode? And these factors will help us gradually learn how to use the newer monitors which are coming on the scene. So for HFrEF, now specifically focusing on HFrEF, we're coming around again when we look at mortality and the disease mechanisms. Milton Packer back in 1992 discussed the neurohormonal hypothesis to explain disease progression in heart failure. And this has clearly been very important in developing therapies that have had a huge benefit on our therapies. However, hemodynamics remains very important, and the combination is even more important. This is looking at the CHAMPION trial at an analysis looking at how the results of the PA pressure monitor depended on the GDMT. And there were 447 patients on either ACE-ARB and or a beta blocker, and they had a 47% lower mortality with PA pressure monitoring, much higher than those patients who did not have the GDMT. And for the patients who were on both ACE-ARBs and beta blockers, there was a 57% lower mortality when these therapies were combined with the PA monitoring. Leading Liv Klein back in response to this to say, we are rediscovering the neurohormonal and hemodynamic duality of heart failure. It's the interplay of neurohormonal and hemodynamic forces that defines heart failure. And most recently in 2024, looking at 1,250 patients who had been in the randomized trials of PA pressure monitoring, showing a significant decrease in mortality at 2 years for a hazard ratio of 0.75. So we can impact mortality, and this is in patients who have heart failure with reduced ejection fraction. I want to mention that we know we can do better to optimize GDMT when we're monitoring PA pressures. Optimizing cardiac filling is important when we're starting beta blockers, as PA pressures can go up when you start beta blockers, so you don't want to start with elevated PA pressures. It's important to help patients tolerate the ARNI, as PA pressures go down with ARNI, and we don't want patients to be too dry to start out. SGLT inhibitors enhance natriuresis and sometimes deplete volume. Once again, we want adequate volume to start this important therapy, particularly in patients who don't need baseline diuretics. Postural hypotension can be due to too much diuresis or too much vasodilation, seriously under-recognized, and when we measure our PA pressures, it will help us to protect against postural hypotension. And we're finding more recently that knowing the PA pressures at different times throughout the day can actually help to avoid that late morning slump when all the medicines kick in at the same time. I'm not going to go through the details of this, but this is actually looking at the seated filling pressures from the Cordella device, looking at the impact of increasing and decreasing loop diuretics shown in the top bar. ARNI shown in the second bar. ARNI also decreased filling pressures within the first 7 days. And if you decrease the ARNI, the filling pressures go up. Same thing is true for the mineralocorticoid antagonists. Beta blockers, we don't have a good handle yet on exactly how filling pressures respond, and we need more data because we don't have that many patients who've had beta blockers adjusted while they've had the monitoring. Perhaps one of the most interesting things that's come up recently is how dramatically digoxin actually affects cardiac filling pressures. This is a study done by Joanne Lindenfeld and her colleagues, looking at the decrease in PA pressures within 14 days after starting digoxin. You can see almost 4 millimeters decrease in PA pressures. It's very important when we're thinking about neurohormonal modulation and our diuretics, we need to move towards where we realize that decongestion is not just diuretics. The neurohormonal modulators and direct vasodilators have a large impact, just reminding us that congestion is a function of volume and vascular tone, and of course, myocardial diastolic function. So now I want to look at HFpEF. In HFpEF, in fact, our goals are more similar than different than with HFpEF. First of all, if you think about it, congestion is central to the definition of HFpEF because we don't have ejection fraction. The symptoms and signs and measurements of congestion are the way that we diagnose it. Also important to realize that neurohormonal activation is much more in HFrEF than HFpEF, so it's not surprising that our neurohormonal modulators don't routinely have the same sort of benefit in HFpEF. And this is emphasized in the 2023 update of the ESC guidelines that for HFpEF, we need to look very carefully at how we define them. Well, HFpEF, it was thought initially that people had flash pulmonary edema in HFpEF. All of a sudden, in the middle of the night, they went into heart failure. And how did that happen? Turns out that they don't look that different than HFrEF. This is back from the Zeil study of the old Chronicle device, looking at what happens to filling pressures prior to a heart failure event with HFpEF in the red line shown compared to the blue line above, which is for HFrEF. You can see that there is a very similar trend, interestingly, at slightly lower PA pressures for HFpEF than for HFrEF. Doesn't start quite as early, but it's still a couple of weeks prior to an event. People have thought about HFpEF as being a stiff disease, so we would need very high filling pressures, in fact, to support cardiac output, but it doesn't seem to be the case. This is looking again back at early COMPASS analyses. I'll show you some more recent ones in a minute, looking at the hazard of heart failure hospitalization in relation to where the mean estimated PA diastolic pressure is running. And you can see that if we look with low ejection fraction, that the risk of heart failure hospitalization goes down steadily, even when you get down to a PA diastolic of 15. For heart failure with preserved ejection fraction, there's also a decline, perhaps maybe more to about 16 or 17 than to 15, but still, as soon as you get above 16, you can see a continued increase in risk. So it doesn't look like patients with HFpEF really need those high filling pressures. And I think these monitors have been extremely helpful for us in sorting that out. If we think about our therapies for HFpEF, the effective ones all have a significant effect to decrease the starting of new loop diuretics, and more commonly to allow them to stop chronic diuretics. You can see, for instance, that the ARNI has very little effect on the diuretics, and in fact has not had much effect on the outcomes of HFpEF. On the other hand, you look at spironolactone, empagliflozin, dapagliflozin, and more recently the GLP-1s, there's a significant effect to decrease the need for diuretics. So it is not surprising, in fact, that hemodynamic guided therapy would be effective for HFpEF, and this has been true. In the original HFpEF group of the CHAMPION trial, almost 50% lower hospitalizations at 18 months. In the post-approval study, the rate of heart failure hospitalization fell from 1.15 to 0.45. If we look at patients who have obesity, both HFpEF and HFrEF, in fact, seem to have more benefit of hemodynamic monitoring in the presence of obesity. And we would expect very high impact of hemodynamic monitoring to help us manage volume status in patients who now finally have some effective weight loss. This is just briefly a slide indicating that when we compare HFrEF and HFpEF in terms of filling pressures, important to look separately at the patients with higher and lower BMI, because the patients with higher BMI have higher filling pressures. But if you divide it like this, you can see that pulmonary artery pressures before and after monitoring, which is shown here in the before and after, the pressures between HFpEF and HFrEF are really remarkably similar. So again, HFpEF is well managed by PA pressure-guided therapy. Interestingly, the number of HFpEF patients needed to treat to prevent one heart failure hospitalization is about 3 with PA pressure-guided therapy, compared to about 40 for SGLT inhibitors. One of the very interesting things that is being elucidated by Mike Zeil is PA pressures are actually related to mortality in HFpEF as well as they are in HFrEF. And this is his data. Now looking at the relationship of PA pressures to mortality for HFrEF, shown in the top line, and HFpEF on the bottom, you can see, similar to the heart failure hospitalization data, that mortality, in fact, can be very clearly related to PA diastolic pressure, with the levels not that dissimilar from HFrEF and HFpEF. I do think there continues to be this signal that there's a little bit of a steeper tail with HFrEF, such that the mortality continues to go down even when we get below a PA diastolic of 15 for HFrEF, but not for HFpEF. And addition, these are the slides I just show you, but also whether it's HFpEF or HFrEF, when we can decrease the PA diastolic pressures even by only 2 millimeters, we see a substantial change in mortality risk. And this is true for both HFpEF and HFrEF. So these outcomes are tightly linked to baseline and changing PA pressures. I just want to go on to very briefly mention the next lessons to learn in heart failure monitoring. We need to learn how to choose signals for patient risk and whether we want messages just for alarms or for daily management. One of the biggest challenges that faces us now who work with these different devices is how to establish the algorithms, both for patient-directed diuretic management, which is well underway now, and we had some previous experience from the laptop trial. But I think we can do much better to have initiation of GDMT guided by the PA pressures with simultaneous blood pressure and heart rate. And our clinical team can use this remote information to help initiate and titrate GDMT. But perhaps one of the really new areas is to think about how can we escalate therapies to treat this persistent pulmonary hypertension, and that should say pulmonary hypertension, beyond diuretics using the neurohormonal modulators and direct vasodilation. And a last exciting point, we are not only going to be using pressures in the seated position, but this is now a special halter to wear the hemodynamic monitor, and this demonstrates in a beautiful study done by Wilfred Mullins and colleagues with this monitor, how we can follow PA pressures during a walk and how much more we're going to learn about how the physiology of heart failure works, but also how we can best adjust our therapies to improve many aspects of heart failure. Thank you so much. It's been such a pleasure to be with you, and I look forward to answering some questions with my colleagues.
Thank you, Dr. Lin, and it's now open for discussion.
Good evening. Thank you for the presentation. Which subgroup of patients, heart failure patients, do you feel would benefit most from PA monitoring?
I think, in my mind, it's the patients who are at the highest risk of having ongoing congestion, the patients who've had at least one heart failure hospitalization, perhaps more, the patients whom you have trouble getting their diuretic dosing, their edema keeps coming back, and you're just not sure where you are. I think patients who are at low risk, who have not demonstrated significant episodes of decompensation, I think we would have a much simpler form of monitoring just to tell us if the patients are beginning to go off the rails. My hope, as I mentioned earlier, is that once we understand this much better, we'll be able to find non-invasive correlates, non-invasive devices that we can use. But frankly, it's hard enough to do the therapies when you have the actual signal that you want. I think to jump quickly to using a signal that is only partly reflective of the physiology, it's going to take us a long time to sort out how those algorithms should look.
Is there any data on patients with lung disease like chronic obstructive pulmonary disease and all? Does it confound the PA pressure monitoring as far as heart failure is concerned?
No, in fact, in the converse, it's been very helpful for us. For instance, for people who have both COPD and heart failure, we can often discern when their increased shortness of breath is not associated with high filling pressures, and then we treat the COPD. Slightly related to that is that there are also small studies which suggest it's extremely helpful in patients who have significant pulmonary hypertension to help monitor that. In an earlier study, many long years ago now, it was suggested that actually the hospitalizations for pulmonary disease were also decreased by having the monitoring, because as we all know, that combination, when you already have COPD and now you have some fluid retention, everything gets worse, that we're able to see decrease in pulmonary hospitalizations as well as in heart failure hospitalizations.
Thank you. Any other questions, please? Dr. Bhupinder, anything? Thank you.
Thank you. Now I request Dr. Bhupendra Singh.
I think there are no other questions. So thank you so much. That was a very nice, lucid, and interesting talk. Thank you so much.
Thank you.
Good evening, everyone. The slides are visible?
Yes. Audible.
Yes, right, sir.
Very good evening to everyone. Thank you for giving me the opportunity to be a part of this beautiful conference, online conference with a multidisciplinary approach. The topic given to me is digitization of rural heart failure care, the challenges and opportunities. So as we know, India faces significant heart failure burden affecting millions with a high hospitalization rate, especially among elderly population. With the given financial constraints due to multiple comorbidities coupled with high in-hospital mortality compared to Western nation. The prevalence increases significantly with the age up to 10% of those over 70 years of age. So, what is the rural heart failure perspective amongst the overall heart failure scenario? There is a delay in the diagnosis. They have a higher rate of medication non-adherence with the worse prognosis than those from the urban area. They receive lesser GDMP. So this is how the rural perspective is amongst the all heart failure patients. So if we compare with the urban heart failure, the rural heart failure, the IHT as a contributory factor is lesser as compared to urban scenario. The major causes predominantly include rheumatic heart disease, cardiomyopathies, right heart failure, and they have got a lower conventional risk factors such as diabetes, hypertension, alcohol, etc. with a younger presentation. They're usually underrepresented in the heart failure trials. So the problems related to rural heart failure are peculiar. They have got access barriers, the distance and the transport issues are there. They live far away from the tertiary care centers or where specifically heart failure care is to be provided. The workforce is short. The nearby PHCs or CHCs, they may not be having the medical specialist or heart failure specialist, so the workforce issues are there. The financial constraints in terms of transport issues, these are important in terms of access with the limited equipment, which probably they are not available in the smaller villages. Even we see that even the facility of electrocardiography is sometimes not available. We forget about echocardiography in the area. So that leads to the diagnostic challenges in the form of, again, the equipment which are not available in the nearby areas wherever the access to a partial access to health system is there in the form of PHCs or even CHCs in the area, in the rural area, thereby leading to delayed diagnosis. All these things eventually lead on to the management deficiencies, causing the suboptimal GDMT, the lower health literacy, and the comorbidities and follow-up is even if the visits are there, the decompensation, hospitalization are there, subsequent follow-ups are affected. Can we digitalize the heart failure care in rural area? Can we implement this? So yes, the answer is yes, but there will be some issues. So traditionally, the digitization was developed to identify and treat early pre-symptomatic stages of heart failure, but now it has been leveraged to promote the implementation of GDMT in the daily clinical practice. So as it has already been discussed, it can be in the form of mHealth, mobile-based devices, or telemedicine, teleconsultation, telemonitoring. It could be invasive, non-invasive, or tele-rehabilitation. So tele-rehabilitation, we should focus on the comprehensive care of heart failure patient, for end-to-end care of the heart failure patient. So it is just a way, how do we telemonitor or the remotely monitor the heart failure things? There are devices and the data is generated and then it can be transmitted through the mobile application or various other apps to the medical practitioners, and then the changes or the modification of the treatment or up titration or the suggestions can be provided to the patient. So telephonically, there can be structured telephonic support. Patient can be called upon, and the drug therapies can be asked. Compliance or the lifestyle measures can be implemented. They can be enforced multiple time, and you can simply ask about the change of body weight, blood pressure, heart rate, devices. It can be checked at the local areas, and you can take help of smartphone based devices, application and text messaging. It gives the health profession the opportunity to interact also with the patient in a less intrusive way. And we have the in terms of monitoring, telemonitoring, there can be non-invasive home-based devices which can monitor the heart rate using photoplethysmography, activity monitors using accelerometry, wristbands, watches. And eventually these things can be integrated with the machine learning AI to further strengthen the non-invasive telemonitoring services. There, as it has already been discussed in the last presentation, the invasive pressure monitoring devices are there. The CardioMEMS, Cordella device, HeartPod. We have pulmonary artery-based devices. We have LA-based devices, RVOT-based devices, which are helpful in managing or finding out the early decompensation. And in the meta-analysis, it was found that the CardioMEMS reduces the total heart failure hospitalization in almost one third, regardless of ejection fraction. There are some issues with the wearable devices in the form of data validity, protection, insurance, and its linkage to the electronic health records. In a recent meta-analysis published in 2021, the mHealth intervention with remote monitoring and clinical feedback reduces mortality and heart failure hospitalization, heart failure related hospitalization, but might not reduce all cause mortality in patients with heart failure. So obviously we have multiple advantages to the management of heart failure if we digitize the heart failure in the rural subsets in the form of early detection and prevention of decompensation, reduction of hospitalization and readmissions, and improved patient self-management, and giving a personalized and data-driven care to the patients, enhanced access to the care, better medication optimization, improved quality of life, and very importantly, which is very pertinent to the low middle income, cost effectiveness for the health system. The patient may not need to travel frequently because there is a need of frequent visit and alteration in the medication if we actually want to optimize the GDMP of the patient. But side by side, there are challenges of the digital health in rural area. If we really want to implement digital health, there are numerous challenges for the digital health in rural area, which might be limited infrastructure, digital divide, socioeconomic barriers, workforce and training constraints, fragmented healthcare system, data privacy and security concerns, device accuracy, reliability, and so on. So the limited infrastructure is basically the poor internet connectivity and lack of access to smartphone, watch, and tablet devices. Nowadays, even though the smartphone services are most of our rural patients are carrying smartphone, but because the internet connectivity may not be there, it's still a problem. So the infrastructure is limited. So there is a concept of digital divide. A person or a patient group with the greatest healthcare need may have a least access to digital technology. So that's the concern if you want to implement digital health in a broader way in the rural area. And sometimes it is difficult to understand and use the written healthcare information by those by people staying in the rural region. Then we have various form of socioeconomic barriers. The workforce and training constraints are definitely there. The community health workers or PHC workers, they may not be able to understand what actually is the digital health we need to. So that workforce is less. The fragmented healthcare system is there. So the coordination between, even if the some digital devices are there to diagnose, but the limited coordination between the rural clinic and the tertiary heart failure center is not there. So even if you diagnose or detect it, if it is not converted into a care providing care to the patient, that particular patient, the whole purpose is lost. Then the data privacy and security concern, the fear of data misuse and breach with low awareness to the cyber security is also the concern. And even though there are multiple devices which are available, the wearable devices are poorly calibrated and affected by improper use. Cultural and behavioral barriers are there. Some of the patients, especially so we see in our clinical practices, the rural patient from the rural area patients, they prefer face-to-face consultation, and there are language barriers. So that's another challenge for the digital health. Yeah, even more important, even if we start a pilot project for the digital heart failure program, it may be perfect, but it may lack long-term funding. So it should be the scalability or sustainability is a concern. Lack of self-sustaining policies and program by stakeholders. And nevertheless, the emergency care limitation. Even when deterioration is detected digitally, the delayed access to the emergency services for various reasons, for the transport reasons or logistic reasons, or the person is staying far away from the services, the long distance to hospital reduces the effectiveness of the early alert. So these are all the challenges which are very important when we are considering digital health in rural heart failure scenario. So can we overcome these challenges? We may not be able to, but to overcome all the challenges. But then we can try to overcome these challenges by strengthening the digital infrastructure, expand broadband or mobile network coverages, or we can use low bandwidth solution, the SMS based reporting, voice calls where internet is limited. Then bridge the digital and health literacy gap. Simple, intuitive devices and app designs, large icons, local language support can help in that way. Hands-on training for patient and caregivers at enrollment, and use community health worker to support daily monitoring and troubleshooting, as it will increase the manpower to support the system. Provide printed guides and video tutorials. Then reduce financial barriers. Then government or NGO subsidies for devices and data plan should come up with to reduce the financial barrier to all these things. Integrate digital heart failure care into universal healthcare coverages. That way, it can partially cover up the financial issues. Use cost benefit tools, the basic BP cuff, weight scales, SMS reminders, which can help in promoting digital health in rural area. The build rural healthcare workforce capacity. Train the nurses, community health workers in remote heart failure monitoring. Medication titration protocols. Telemonitoring program linking rural providers to heart failure specialists. So this particular program is already there. We are having e-Sanjeevani module of telemedicine, which can be there from a tertiary care hospital, as we are using here at AIMS also. From doctor to doctor, a specialist can interact with a doctor sitting at a healthcare worker sitting at a community health center or PHC. So looking at the clinical scenario, the person can be prescribed some form of medication, basic medication called upon as per as you can triage the patient, and so that form of services are already there in our healthcare system. So telemonitoring program linking the rural providers to heart failure specialists. This is one of the very important aspect which has to be considered and upscaled in a larger manner. So then we need to improve system integration and care coordination. Use interoperable digital platform compatible with electronic health records. Establish hub and spoke model. Hub and spoke model is already there with the STEMI program, and for the STEMI it's already well proven, but it can be utilized in a similar way for the heart failure management. A person sitting at periphery in the rural area can visit someone, and they can be integrated or referred or treated as a part of hub and the spoke model. Clear escalation pathways for detected deterioration should be there. Ensure data privacy and build trust. Use secure, compliant, and digital platforms. develop clear national policies on digital health governance. Our digital health or telemedicine latest guidelines are 2019. When the COVID pandemic was there, the guidelines were issued and we are following that. And there are so many restrictions and there are so many ethical issues in the telemedicine guideline. This need to be improvised upon if we really want to upscale the telemedicine and telemonitoring in heart failure in any subset, let it be rural or urban. Improper device accuracy and reliability. Selected, validated, and clinically approved devices should be used. Regular calibration and quality check is a major concern which has to be done on a regular basis. Simplify measurements like once they weight, blood pressure, heart rate monitoring can be done. Strengthen the emergency and referral program. Link digital alerts to the local emergency services. So that's the important aspect. Even if we find out the deterioration by digital monitoring or telemonitoring, if a patient is not able to receive the emergency care, that's a major lack or the final endpoint is lost. Also link digital alerts to the local emergency services and predefine referral and transport protocols. Coordinate with the regional ambulance networks. So these are some of the things, the way we can overcome these challenges of telemedicine in the heart failure in the rural area. So just to summarize, the rural heart failure patients, they are underdiagnosed, undertreated with a high morbidity and mortality with a younger subset. So we definitely need to digitize the heart failure management in the rural area, which has got advantages in the form of early detection and treatment, enhanced access to care, better GDMT, improved quality of life, and definitely very important aspect being cost effective. And challenges are there in to implement this program in rural area in the form of poor infrastructure, lesser workforce, device accuracy issues, sustainability and scalability, and emergency care. But we can have some of the solutions by strengthening the digital infrastructure using a spoke and the hub model as is been used for the STEMI care nowadays in India. Involvement of stakeholders, rural workforce increase, better devices, strengthen the referral pathways. Thank you.
Thank you, Dr. Bhupendra Singh, for that excellent talk, and it's open for discussion.
I have one question and a comment. The community health workers are already overburdened in the sense they're taking care of maternal health, immunization, childhood, diabetes, hypertension, and so many other things. So, for this to work, I think either we need a dedicated workforce or we need a system where we involve a caregiver or the patient himself as or a relative. Because we put more burden on the community health worker, it probably may not work. So, do you think that we should think of a dedicated workforce for telemedicine or?
Definitely, sir. It is a very important point which you have raised. So at the end, everything comes to a overburdened healthcare system in India. Let it be the tertiary care center, even the PHC or CHC. So if we want to focus on heart failure perspective, we really have to start what you are suggesting, that it has to be dedicated force work. And we can take help of the relatives which are there. If even if it is a rural area, they are more or less they are staying in a combined family rather than nuclear family in the urban area. So they can be helpful to each other. They can be trained as a partial, like the way we train the nurses. They can also be trained partially in terms of giving, monitoring the blood pressure, heart rate. There are devices which are easily available devices. Now they can measure blood pressure, weight monitoring. So small things can be taught to them, and definitely a dedicated force will help in upscaling the telemedicine services. When we have to focus rather than all cardiovascular illness, if we really want to decrease the outcome, improve the outcome of heart failure, we focus on hyper, just a risk factor management and heart failure as a disease management with a separate workforce. Yes, definitely.
Thank you. Any other questions?
I Lynn again, this is just wonderful, and it's so visionary, I think, of an obvious group that needs more care. It seems to me, again, we have the same problems with not enough healthcare workers, but I feel like we're not doing enough to combine diseases. If you think 30 to 40% of patients with heart failure have diabetes, have COPD, that maybe we could have some initial levels of the social healthcare who are already dealing with other chronic illnesses that overlap. I had a question for you. I think many people have mentioned today that we're just not diagnosing it early enough. I don't know of any, but I wondered if you know of any just even phone surveys, something just, if you answered yes to 5 of the following 8 questions, then you should have a telediscussion with someone about whether you should be seen for possible heart failure. Just because there's so many people who've had these symptoms for months, and they just didn't do anything about it until it's harder to help them when they present late. So I'm wondering about some kind of screening that we could do using phones or something else to pick them up earlier.
That's a very rather a suggestion to diagnose or to stratify the patient who can be referred to, outside home. They can come to go to a nearby facility, healthcare facility, a preliminary questionnaire that can be created. That those things, the surveys are there. Probably, to my knowledge, Dr. Ajay Bahl can further guide me. That to my knowledge, for heart failure per se, the screening questionnaires are not there, but they're there for other purposes. But it can be implemented in order to. The only thing is the clinical assessment or asking a dyspnea would be so vague that there will be so many patients who will be giving that sort. Until unless we add something to it, just rather than symptom, we add some sort of diagnostic evaluation, or we create a protocol or an algorithm. If these things are there, let us go for a pro BNP on the basis of screening. So that could be one of the way, because again there are AI protocols for the ECG, but then for that ECG is required. So clinical symptoms, So clinical symptoms may be vague, but then we try to subclassify those clinical patients into probable heart failure. Maybe a anti-pro-BNP may add to that. It could be possible. It can be created. An algorithm can be created, a clinical followed by some form of basic investigation, and further referral to the nearby facility. What do you say, sir? Your comment on this?
Yes,
It's an pertinent thing.
Yes, I think the healthcare system, especially the healthcare workers in rural area, they're overburdened. And like hypertension, if we look at the national data, the good control of hypertension is only around 12 to 14%. So I think the priority is to improve the hypertension control, identify hypertension early, treat diabetes. And I don't think heart failure is that high on the priority list of the healthcare worker, the community health worker right now.
Yes, sir. Yes, sir. That's there. Correct.
Thank you. There are no other questions. Thank you, Dr. Pavitra Singh.
I
Next
think
speaker.
there is a change in the program. Dr. Praya cannot present due to some emergency, so we will probably have it tomorrow. So we will have 2 poster presentations. One of them by Dr. Anand Paramasivan. This is only for 2 minutes. We will just show the slide. Dr. Anand, you can share the slide and show. Dr. Anand, are you around?
Yes.
Please show the slide.
Is it visible, sir?
Yeah, it's visible. Yeah.
Yeah. Good evening, everybody. Thank you for giving me an opportunity to present in the prestigious.
You can make it full screen.
Yes, sir. Yes. Thank you, sir. So I'm just going to give a small note about the use of digital tools in the management of heart failure effectively in the coming years. Heart failure affects 64 million people 64 million people globally. Nearly 25% of the patients are rehospitalized within 1 month of discharge. Despite therapeutic advances, 5-year survival remains 50%, which is equivalent to the many cancers. What are all the digital tools which are available across the heart failure treatment continuum? Start from initial detection and diagnosis. There are risk prediction model are being developed, AI assisted electronic health record analysis, AI enabled electrocardiogram algorithm, smart stethoscope, and AI echocardiography. The second important thing in the implementation of the guideline directed medical treatment. Today it is a very abysmal prevalence of using the GDMT in the heart failure management. Electronic decision support, virtual wards, web-based registries, GDMT underused worldwide has been documented in the recent studies. It is about 40 to 50% in Europe, 23 to 36% in America, and 19% in the low and middle income countries. The many trials which have proved that the GDMT is of utmost importance in mitigating the heart failure related morbidities include COACH, PROMPT HF, BETTER, CARE HF, EPIC HF, STRONG HF, and MEDLEY titrate studies. And the digital tool which are available in the monitoring and the management of chronic HF management include mHealth apps, wearables, implantable devices, hemodynamic monitoring, dielectric sensing, mechanoelectrocardiography, and patch-based sensors. HF clinical research are being digitalized and AI-driven, includes decentralized trials, AI-driven analytics, and multi-omics integrations. The evidence which scores that the AI integrated management of heart failure as sure success includes Watch DM score, UK Biobank low leg bioimpedance marker, AA ECG stethoscope screening, telemonitoring home hospitalization, and AHA HF helper app, Biostat, CHF multi-omic studies. The drawback in using the AI-driven app or management thing includes the data privacy concern, interoperability issues, cost, digital divide, need for validation, and risk of alert fatigue and clinician overload. Conclusion, the digital tools can bridge major gap in HF care from early detection to long-term monitoring, particularly in low and middle income country. Just Dr. Bhupinder Singh has informed, the integration of these digital tools into the primary care practice will definitely help in effective management of the heart failure patient. With rapid technological advances and global connectivity, the digital health is poised to become an integral part of HF management. Thank you, sir.
Thank you, Dr. Anand. We will move to the next presenter, Dr. Balaji. She is around. Dr. Balaji. Nivedita Balaji. She is around. I don't see her. So thank you everyone for the today's presentations. I thank all the presenters and all the chairpersons and moderators for having a wonderful session. Thank you, Dr. Lin, for staying along and having your comments.
Wonderful. It's been wonderful. I've learned so much. Thanks for wonderful talks.
Uday, any comments from you?
No, thank you very much. I was quietly listening. I think this has been a great session. Truly, I really appreciate all the speakers. Fantastic.
Kartha sir, any closing comments? So thank you everyone. Good night. Tomorrow we will start the session at 6 o'clock. Two sessions are there, basically on sensors to decisions, devices like left bundle branch music. Very interesting talks, AI-driven prediction models, drug design using AI in heart failure, epidemic preparedness, use of AI, and mobile applications in heart failure. All those topics are there. So very interesting topics. Please do join at 6 o'clock. The link will be shared to you all. Thank you, everyone. Good night.
Good night.